Thank you, Dr. Jaffrey. So I just want to thank everybody and the Michigan GI Society for having me. It's an honor to give you guys a talk today. So should be able to go ahead. So no financial relationships to disclose. So alcohol-related liver disease is a spectrum of liver disease, just like metabolic-associated liver disease. And it starts off obviously with normal appearing liver hair on a biopsy in the bottom left, and then with harmful alcohol use, a good percentage, a very high percentage of those patients will develop hepatic steatosis, which you can see there, the little white circles is the fat within the liver. And then a proportion of those patients with ongoing alcohol use will develop hepatic fibrosis. Some will present with alcohol-related hepatitis, which we all see and we'll talk more about in a little bit. And then a subset of those patients will go on to develop cirrhosis, which puts them at risk for decompensation, including hepatocellular carcinoma, ascites, encephalopathy, and potential need for liver transplantation. Risk factors for alcohol-related liver disease, aside from harmful alcohol use, include things like gender, females being more susceptible to alcohol-related liver disease with less amounts of alcohol. We do know obesity and other concomitant liver diseases, such as viral hepatitis, can play a role in the acceleration of the fibrosis of liver disease. So alcohol-related liver disease is the leading cause of preventable liver morbidity and mortality in the US and worldwide. And so I know I've been talking with a lot of you here over the last day and a half, and I think everybody is seeing a huge increase in alcohol-related liver disease, both in the clinics and in hospitals. And so that is universal. The main risk factor for alcohol-related liver disease is harmful drinking, and we'll talk more about what that means as well. Half of the deaths in the United States from cirrhosis are related to alcohol. So obviously this is a huge problem. I can't emphasize that enough. More and more studies, have been showing that really there's probably not a big benefit from alcohol. I mean, I remember growing up, you hear, oh, red wine's good for your heart or this or that, but more and more studies have shown there's probably relatively limited benefit for alcohol use. And like I already mentioned in the prior slide, other liver diseases, whether it be metabolic-associated liver disease or viral hepatitis, PSC, PBC, other liver diseases, when you add alcohol to it, accelerates the fibrosis process. So this slide, I think I put this in here because I think it's important, and I think it's something that we all need to understand, because I have a lot of residents and fellows, even PCPs, who don't quite get this. So not all alcohol is created equal, but your liver sees it pretty much all the same. And so that's kind of a misconception among patients. And so an alcohol equivalent, so a 12-ounce beer, about 4 or 5%, your typical beer, is equal to a 5-ounce glass of wine, which is equal to a 2 or 3 ounce glass of fortified wine, which is also equal to about 1.5 ounces of liquor like vodka, tequila, bourbon. And some with the new bourbons, that's a big trend now too. There's higher proof bourbons, 120 proof, so 60% alcohol, so there's much higher levels of alcohol. And I always tell patients, and I always tell residents and fellows and other providers too, it's really important when you're talking to patients and you're asking them how much they drink, because they'll tell you, well, I have 2 drinks, maybe 3 drinks a night. Well, my follow-up question is always, how much is in a drink? Because you'll see that most patients are not measuring, like when you're at a bar, they're not measuring, and so they'll just pour some in, and 2 or 3 drinks can be more like 8 or 9. I remember one time I had a guy who said, I don't drink much. I only have 2 drinks a night. And I said, well, okay, I'm at your house, it's Friday night, make me a drink. So he said, well, I get a glass about this big, and I put about this much Jack Daniels in, and I splash a Coke. So he's drinking 1/5 of Jack Daniels a day, but to him, those 2 drinks. And the other thing is that, patients will say, I don't drink. Okay, I just have beer. How many? Well, 12 a day, but I don't drink. I don't drink the hard stuff. And so it's a real big misconception among patients. I'm sure you guys have seen it too. So harmful drinking is classified by greater than 3 drinks a day for men, or 21 in a week, and then 2 a day for women, or 14 in a week. So alcohol use disorder, actually, there's a diagnostic criteria, then DSM-5 defines alcohol use disorder as a problematic pattern of alcohol use that leads to clinically significant impairment or distress. And we classify alcohol use disorder as mild, moderate, or severe, and that's the number of symptoms based on the questionnaire. And then binge drinking is classified as 5 drinks for men, or 4 drinks for women, or more over a 2-hour period. And I know nobody here Friday at the reception qualified for that, so that's good. Okay, so the alcohol use disorder questionnaire. So this is a long questionnaire. I'll just touch base on a couple of the points, but essentially these are all the questions that if you're doing a real deep dive, and our social workers and our psychologists do this with patients, but these are the questions you ask patients to kind of grade how severe their alcohol use disorder is. And these things include, are you drinking more alcohol over a longer period of time than you're intended? Is it really interfering with your life? Are you having cravings for alcohol? Are you developing tolerance to alcohol? Are you having, or have you ever had withdrawal symptoms? And are you using it in situations where it's hazardous? Is it affecting your life or your work? And so based on the response to the questionnaire, you can grade it as mild, moderate, or severe. More than 6 of these equals severe alcohol use disorder. And so this slide, I think, is what I kind of touched base in the very beginning. What we've all been experiencing in our clinics and in the hospital is that alcohol use is very, very prevalent. And so in the US, and this is 2 years ago, but in the US, about 85% of people 18 or older said they drank at some point in their life. Binge drinking, 25% about patients, so 1 in 4 had binge drank in the last month alone. And so it's estimated about 10% of the population in the US are affected by alcohol use disorder. And so 4 million emergency department visits every year for alcohol use disorder, so very, very big numbers. So the other way you can detect alcohol use disorder kind of quickly in clinic would be an audit test. And so there's the general audit test, which is a 10-question test to identify risky or harmful drinking, but then there's the audit C, which is a 3-question kind of abbreviated test that you can ask your patients to identify harmful alcohol use. And if that's positive, then you can refer or talk to them more about their alcohol use. And it's 3 questions. How often do you drink a drink containing alcohol? Is it never, monthly or less, a couple times per month, a couple times per week, or 4 more times per week? How many alcohol drinks do you have on a typical day when you are drinking? And then how often do you have 6 or more drinks in a single session? And at-risk drinkers, for men, they score 5 or more, women it's 4 or more on this. And so then we refer them. So who should be screened? I agree with the slide here, but this is in the guidelines, but everybody, pretty much. I mean, everybody in primary care, definitely everybody in the hepatology clinic, whether they're seeing me for fatty liver disease or PSC or Hep C, I ask every single patient, everybody that shows up to the emergency department, you don't know if alcohol is playing a role. Maybe they have a broken arm or something, or were they drinking when they fell? I see that actually quite a bit. And then anybody who has an inpatient admission is recommended they be screened for alcohol use disorder. And a couple of things that you can do right away, obviously, would be a brief intervention, talking to these patients about harmful alcohol use and how it can affect their liver. We'll talk about pharmacotherapy and then referral. And so the patients, like the bottom, like I said, audit C of more than 4, or an audit greater than 8, or they qualify for binge drinking, we can refer those patients. So how do you know, or what can clue you in on alcohol use disorder or alcohol-related liver disease? And so obviously labs, so biomarkers. So when you're getting a complete metabolic panel, you'll often see the AST greater than ALT. I think at this point now, most hepatologists and probably a lot of GI docs can look at a CMP and say, oh, this person looks like they're drinking, or at least definitely lead you that way. So AST greater than ALT, usually 1.5 times or 2 times the ALT, elevated bilirubin or GGT, and then a macrocytic anemia as well. And these are all different biomarkers of alcohol use I put down here. I'll just highlight a couple of them that we use or that I use in my practice. So the second one down there, the ETG or ethylglucuronide, that's in the urine, and that looks at alcohol use for about the last 3 days or so. And then PEth, the one at the bottom with the red arrow, that's one that we use very, very frequently in our clinics and in transplant clinic as well. It's a very specific test. It is a blood test, and it looks at alcohol use over the last, I would say, 3 to 4 weeks. And so I find it helpful in practice, like when someone comes in, even if they're inebriated, their alcohol level is 300, I tell the fellow, get a PEth. And they say, why? He's drinking, they're drinking. Well, I said, yeah, but a baseline is very important because, the PEth at that point might be 1,000, and then they come in 2 months later and they say they're not drinking anymore, or a month and a half later, and you check a PEth and maybe it's down to 50 or 75. And so they're probably being truthful. And then, should that patient develop severe alcohol-related hepatitis and need transplant or something like that, we then have a pattern of, or at least a baseline, and then you can follow that going forward. So I get a PEth pretty much in everybody that comes in just as a baseline. All right, so the treatment for alcohol use disorder is definitely multidisciplinary. One person cannot do this on their own. Often it involves our social worker, referral to addiction specialist. You can use motivational interviewing in the clinic if you have time, or brief intervention. And then psychiatry or psychology can perform cognitive behavioral therapy, motivational therapy, and then there's also group therapy or mutual aid support through AA, or Smart Recovery is one our patients use a lot. And one of the good things about the pandemic is that a lot of this is virtual now too. So AA can be virtual, Smart Recovery is virtual, and a lot of therapy is offered virtually as well. But the most important thing I tell patients is abstinence is the best predictor for outcomes. It's the most important thing for survival for alcohol use disorder. You have to stop drinking. So what can we do? What medications do we have? Well, there's a handful of medications we use for alcohol relapse prevention. So a couple I wanted to highlight. One would be naltrexone. And so there's a pill of naltrexone, then there's Vivitrol, which is a monthly shot. It is not used in decompensated cirrhosis, but in alcohol use disorder or compensated cirrhosis, you can use naltrexone, and that's an opiate receptor antagonist. Acamprosate or Camprol, we use that very frequently, so that's a pill. That's 3 times a day, so the dosing is a bit burdensome, but we do use that. You want to be careful in renal dysfunction, and so usually you have to either reduce the dose, or if they have severe renal disease, you can't use that one. Other things that have been studied are gabapentin, baclofen, and Topamax. And then one thing I think Dr. Hassan's going to touch on from DDW, but there are some data published even this year about the GLP-1 agonists, so semaglutide, also not only helping reducing the craving for food and obesity, but also there's some data to suggest that we may be able to use those for alcohol use disorder as well. The number needed to treat to prevent harmful drinking for Camprol is about 12, and then it's 20 for naltrexone. For a while there was actually a shortage of Camprol, then it came back, and then there was a shortage again. So last I heard, there's still a little bit of a shortage, and some patients are having difficulty getting it, but I still prescribe it. Then we usually work with our specialty pharmacy if needed. So alcohol-related hepatitis. So I think this is something that, is so prevalent now. We see it all the time. I think probably 20, 30%, maybe even 40% of our inpatient list is related to alcohol-related hepatitis. And so it's defined as the onset of jaundice within 8 weeks of alcohol use, and typically it's heavy consumption for at least 6 months, usually daily. Like I said, less than 2 months of abstinence, and you'll see the same thing, AST greater than ALT. But typically, if you see an AST/ALT over 400, 500, there's probably something else going on as well. So I'm looking for other reasons for that. Maybe if the AST is 1,000, maybe they fell down and they were they have rhabdo or something like that. They weren't found for a day, or they have concomitant viral hepatitis or something else. So I usually do a workup for those as well. I'll do a workup anyway, but particularly if it's over those levels. And then they have hyperbilirubinemia. Again, ruling out other causes of liver disease is important. Very, very rarely do you ever need to do a biopsy for these patients. Usually when I see a biopsy, it's if they were somewhere else and they have a biopsy and then they come to us or are transferred to us. But if you were to do a biopsy, you see a lot of the same features that you see with metabolic-associated liver disease. So you see steatosis, you see inflammation with ballooning hepatocytes, and then the thing is you see a lot of Mallory-Dink bodies, which are these intermediate filaments that you see, they kind of stain pink. So you see a lot of those, and that can kind of be a tip-off for alcohol-related liver disease. So prognostication is important, right? So you want to know who do you think is going to do well and who's going to do poorly, who might you need to talk about transplant with. And so there's a lot of different things you can use. We tend to use the Maddrey discriminant function, MDF, and MELD. And then the one there on the bottom, the Lille score, that's used to prognosticate patients who are on prednisolone. Are they going to do well? Should they continue for the 28 days or should you stop? There's a 7-day and there's a 4-day score. Both have been shown to be accurate. So we use one of those two if we're doing prednisolone to check the response after about 7 days. And then there's the ABIC score as well that predicts 90-day and 1-year survival. So treatment, so obviously abstinence. We always tell patients you have to stop drinking. Of course, the risk of decompensation, bleeding, death, HCC are high. Nutrition is very important with alcohol-related liver disease and alcohol-related hepatitis particularly. So we always say high-protein diet. We always get our nutritionists or dietitians involved in the hospital with vitamin supplementation, thiamine, multivitamin. And then steroid use with or without NAC, but steroids I think is the biggest debate in this group. And then some studies, so maybe GCSF in the future has been looked at. So I wanted to touch base a little bit on the STOP-AH trial. This is a large trial that used prednisolone or pentoxifylline for alcohol-related hepatitis. It was a multi-center, double-blind. It was a 2x2 factorial randomized trial. There were 1,100 patients and looked at 28-day survival in these groups. Initially, it was not significant, but a post-hoc multivariable analysis showed that prednisolone probably did have some survival benefit. And then this is a meta-analysis for steroids and the risk of death in 28 days for alcohol-related hepatitis, and it did show some improvement in the 28-day mortality. So I think the guidelines would suggest too that using prednisolone is a good idea for patients who qualify. And so this comes from the AASLD. This is their guideline or their pathway for using steroids or treatment of alcohol-related hepatitis. So the first thing is, who doesn't qualify? What's the contraindication for steroids? And so these are patients with uncontrolled infections, severe renal injury, the creatinine greater than 2.5, which unfortunately is a lot of our patients, uncontrolled upper GI bleeding, This doesn't mean any GI bleed. If they bled and they stopped and it's controlled, whether it be an ulcer or something like that, they could still be a candidate for prednisolone. If they have concomitant viral hepatitis or multi-organ failure and shock, although some of the patients in shock are on stress dose steroids. And so if they're eligible for therapy, the dose is 40 milligrams of prednisolone or an equivalent. And then nutrition, like I said, is important. Then after the 7-day mark, we check the Lille score. If they're responding, then we can continue prednisolone over 28 days, followed by a taper. If they're not responding, then we usually just stop the prednisolone. If they're not eligible for therapy, then we think at that point, are they candidate for transplant? And we'll talk a little bit more about that in a minute, but that's usually the next step, just because the mortality for alcohol-related hepatitis is so high. All right, so what has been tried that really hasn't shown any benefit? Well, a lot of different things. They're listed here, but pentoxifylline, TNF-alpha inhibitors, acetyldenocylmethionine, vitamin E, insulin, propylthiouracil. All these have been studied in alcohol-related hepatitis, and none of them have really shown any benefit. So transplant. So for a long time, and it's still kind of I would say a stigma or a myth out there that everyone has to be sober for 6 months. There's this magical 6-month cutoff, which really isn't true. There's been a big paradigm shift in the transplant world for alcohol-related hepatitis over the last multiple years at this point, to transplant patients within that 6 months of sobriety. And so one of the reasons is that I just told you that alcohol-related hepatitis has a significant mortality with it. So waiting 6 months, a lot of these patients are not going to survive. They don't have the time. And as you probably have seen in your practice, a lot of these patients are younger and they do quite well after transplant. And I'll show you some data. So it makes sense to look at these patients a little bit closer within that 6-month time frame. And so when you carefully select these patients, and we often use what's called the Dallas Consensus Criteria as a framework, our institution does, once you carefully select these patients, they do very, very well. But it does require a multidisciplinary approach. It's not just the hepatologist or the surgeons, but we use our transplant social worker and our psychologist, and it's really a group effort. And when you look at relapse, it's actually relatively similar compared to the traditional 6-month wait time. And so the Dallas Consensus, this was a group, and they met in Dallas, and they came up with a consensus of, who should we be selecting for alcohol-related hepatitis when we're looking at transplant. So these are patients who showed up for the first time for decompensated liver disease. This is not the patient who, the frequent flyer who is in there, every 3 months or every week, with alcohol withdrawal. That is not what we're talking about. This is someone who was unaware that they had liver disease. They showed up with severe alcohol-related hepatitis, and they didn't know about their disease, and this is sort of the first presentation. They also have acceptable risk for relapse. And so what that means is, once our social worker, addiction specialist, whomever it may be, talks with them, these are patients who have good insight into their liver disease. They understand that it's causing them a problem. They know that it's interfering with their life, and they understand that it's causing their liver disease. And you'd be surprised how many patients don't. You can sit there and talk with them, and they I don't think I have a problem, or I don't really drink that much. It's not those patients. It's the patients who really accept their condition and the fact that they have alcohol use disorder. Patients who have done rehab, 7 times, 8 times, 10 times, I've seen it many times. Those are not the patients we're talking about. Those are patients at extremely high risk for relapse after transplant. Also, we look for other substance use. So are they using cocaine or heroin or things like that? Those also increase their risk for relapse or addiction transference. And we have to have them commit. And so I know that, when you're talking about, do you want to die or get a transplant? Yeah, everyone's going to say, I'll commit, or most patients will, but it's important. And so we do have them sign a document about committing to lifelong sobriety and agreeing to do therapy post-transplant. And then social support is very important. And so having a good family or a good network that's going to help them both medically, but also help their sobriety. Do they have a spouse at home that drinks every night with them? That's been their drinking buddy for 30 years, and that's where they're going to go? Well, that's probably not a good idea. And a lot of times that's what happens, and a lot of times that's the situations we're in. But if that person commits to sobriety too, then we work with these patients. So so this was the big U.S. Accelerate AH trial. So this was a multi-center trial for alcohol-related hepatitis amongst 12 different centers in patients with less than 6 months absence. It was a retrospective look at these patients. And the survival, and you look at 1-year survival is 94%, 3-year survival 84%. Great numbers. This is excellent survival. And again, these patients typically are younger. They typically don't have any other significant medical comorbidities. Of course, some do, but it's not necessarily like, the 65-year-old, MASH patient with heart disease and diabetes and everything else. These are sometimes 28-year-olds, 30-year-olds who really are healthy otherwise. So they do well. And then alcohol use after, so sustained alcohol use at 1 year is about 10%, and 3 years about 17%. So the risk of relapse is relatively low. It's not zero, and it's never going to be zero, but there are ways we can try to help them with pharmacotherapy and therapy pre and post-transplant to try to help mitigate that risk. So last, I just want to touch a little bit on our program here at Corewell, and I'm sure we can hear about these guys too, about what they do. So we have what we call an alcohol-induced liver injury program, and so it's essentially what I just mentioned, these patients with alcohol-related hepatitis or cirrhosis who come in within that 6-month of sobriety period who have severe alcohol-related liver injury who may need to be transplanted. So this is our data. So the first graph there on the left, this is the percent of patients with a positive path within 12 months post-transplant. So I already talked to you about the risk of recidivism. And our numbers here, you're looking at probably 10-12% is about what the Accelerate trial showed. And then the average days sober prior to transplant is about 3 months, 2 to 3 months. And that's also pretty similar to what the Accelerate trial was. I think it was around 60 days. And so the number of transplants we're doing for these patients, I mean, we're doing, between 5 and 8 a year this year. This is as of May. There's actually, I can think of 2 or 3 added to that last column already that we've transplanted within the last month that were severe alcohol-related hepatitis. And then the survival rate, aside from 2023, that was not related, those deaths were not related to alcohol, that was something else. The survival rate at 1 year has been 100% for us. So very good data.
Talk. So my task was to update the audience on hepatology updates from DDW. So there's a lot of information that was presented at DDW, and I'm a very clinical guy. So whenever I go through these topics, I want to see, all right, which one of these studies or information are things that I can kind of directly use in clinical practice from day one. So I found a few interesting things that kind of cover broad topics in hepatology that I think we see every day. So I think will be useful. So I have no financial disclosures. So I'm really happy that I'm following Brian after his talk because he did a really good job about talking about alcoholic liver disease. But there's a certain concept in alcoholic liver disease and fatty liver disease in general that I think we should all be aware of. So we're probably all aware that last year there was a big shift in the nomenclature for non-alcoholic fatty liver disease, right? There was a change from the non-alcoholic component to diagnosing it in a term that's more comprehensive, metabolic associated steatotic liver disease, to give emphasis on those metabolic factors that drive that liver disease condition. All the more important because that's been the driving factor for the investigations and initiation of different treatment strategies for fatty liver disease, hence the more interest in the use of GLP-1 receptor agonists in fatty liver disease and phase 2 trials that are coming in that region. But one of the intended or unintended consequences of that also was, well, you had to stratify different patients with fatty liver disease. And we carved out a subset of patients who have metabolic syndrome, metabolic factors that promote steatosis, but also have alcohol use that might not qualify them from independently developing alcoholic liver disease, but have some form of alcohol use. And I would argue that if you take a deep dive into your patients who have fatty liver disease and really talk to them about alcohol use, you're going to find a lot more of these patients falling into this gray zone that's termed MET-ALD, or metabolic liver disease with an alcohol component. And because of that, we have to kind of open our minds in terms of what treatment opportunities are there for these patients. Now, we talked about how the mainstay of alcoholic liver disease management is abstinence, and we have medications for that. But when there is a metabolic component in that issue as well, does the treatment for metabolic conditions in patients with MET-ALD with all the treatment options that we have, does that influence just their metabolic component, or does that influence their alcohol use component as well? And there's been a lot of studies looking at how GLP-1 receptor agonists affect alcohol use and clinical outcomes for patients with MET-ALD. And one of the interesting studies that came out of St. Louis this year was evaluating the roles of GLP-1 receptor agonists in clinical outcomes and disease progression of patients with MET-ALD and alcohol use disorder. So as Brian already mentioned, alcoholic liver disease, pretty common, very severe, basically a scourge of liver disease that we're dealing with right now. And we're seeing a lot more patients being on or being prescribed GLP-1 receptor agonists for therapeutic purposes, metabolic issues. And then there has been some data that the use of GLP-1 receptor agonists does affect alcohol behavior in these patients. There have been studies that have shown that not only does GLP-1 receptor agonists decrease food intake and cravings, but it also helps with alcohol use disorder, similar to naltrexone, similar to Camprol. It helps reduces the days of heavy drinking, helps reduces cravings in a multitude of studies, both in the United States and outside the United States too. And then when you look at the bigger picture in terms of clinical outcomes in patients with alcohol use disorder, certain countries like in Northern Europe that have socialized medicine, have registries for all patients who live within the country, they have really good population-based studies when GLP-1 receptor agonists are prescribed in their patients to kind of follow them and see how they do. And this study out of Sweden that looked at patients who have alcohol use disorder who are prescribed GLP-1 receptor agonists, how did they do in terms of hospitalizations for any alcohol-related issue, whether it is alcoholic hepatitis, suicide ideations, withdrawals. They saw that there was a dramatic incidence in those outcomes. So it kind of led to the question to say, all right, in patients who are taking GLP-1 receptor agonists and who have liver disease, what other hard outcomes can we look at? And is there any signal that maybe the use of these GLP-1 receptor agonists has a positive impact on those? So this study was a retrospective cohort study that looked at a lot of patients within the US, all adults who had alcoholic liver disease. So that means alcoholic hepatitis, alcoholic cirrhosis, the whole gamut of conditions. And they looked at pretty significant outcomes that we see every day. The incidence of alcoholic-associated hepatitis, cirrhosis, hepatocellular carcinoma, all-cause mortality, hospitalizations, and ICU admissions. And these are the common settings that we see a lot of patients with alcohol use disorder. They started off with over 1 million patients, randomized them, and then propensity matched about 900 or 9,000 patients in each category and looked for these significant outcomes. And the results were not surprisingly pretty good. When you looked at the rate of the incidence of these hard outcomes within 10 years of being prescribed a GLP-1 receptor agonist, it was associated with a decrease in a lot of these hard outcomes, a decrease in the rate of alcohol-associated hepatitis, cirrhosis, all-cause mortality, and also importantly, all-cause hospitalizations and healthcare costs. So it's pretty interesting that in patients, maybe even in those specific patients who have met ALD, we always focus on the alcohol use, but sometimes the use of these GLP-1 receptor agonists could really impact these patients in terms of their clinical outcome. And it might not be just working on their metabolic component, but probably would be working on their alcohol use disorder component as well. So the conclusions were great. This is a limited study. It's retrospective. The propensity matching was really based upon a few factors. They didn't really factor in BMI, so they didn't really focus that much on the metabolic component. But it's still food for thought. And like I said, there's a lot of preceding data that showed that this is probably an interesting avenue for the management of these patients with alcoholic liver disease because it is multimodal, it is multifactorial, and all the treatments that we have right now are not that pretty effective. The second thing that I wanted to talk about was this understanding about cirrhosis and portal hypertension. Again, another common symptom complex that we see in a lot of our patients. And the biggest issue here is to try to understand that there has been over the last couple of years a paradigm shift into more of a preventative hepatology mind frame to prevent your cirrhotic patient from having the initial bout of decompensation and how we kind of monitor and triage these patients in a particular way. So we all understand the pathophysiology of cirrhosis and portal hypertension. You have chronic liver disease that leads to scarring, leads to structural changes within the sinusoids within the liver, leading to significant resistance. And as a result of that, you have splanchnic vasodilation, increasing the outflow within the channels that can lead to varices, ascites, and the development of clinically significant portal hypertension. And especially when it comes to certain complications like esophageal varices, the main risk factor there isn't really the coagulopathy or something else like that. It's mainly the degree of portal hypertension and the size of the varices that predicts outcomes in terms of bleeding and mortality. So just like in fatty liver disease, when we know that you don't have to be all the way to cirrhosis to have bad outcomes, but when you start to have a level 2 fibrosis, that's when you have an inflection point in which your liver-related and all-cause mortality goes higher. The same thing in patients who have chronic liver disease. We realize that you don't have to have that first bout of the development of ascites or variceal bleeding for you to have bad related outcomes. You can have advanced liver disease with clinically significant portal hypertension, meaning a hepatic venous pressure gradient of 10, and that is the inflection point where the risk of decompensation is about 10% per year. So the important thing now is to identify these patients with chronic liver disease who have clinically significant portal hypertension to prevent the initial decompensation event and reduce negative outcomes. So how do we identify patients with clinically significant portal hypertension? There's a couple of ways. So obviously the direct way is to measure the portal pressures themselves. This is usually done when you have a transjugular liver biopsy. Normal portal pressures are less than 5 millimeters of mercury. 5 to 10 is portal hypertension, but that's usually not clinically significant. And when the gradient is above 10, that's when it's diagnosed as clinically significant portal hypertension that can lead to complications. On endoscopy, varices of any size and portal hypertensive gastropathy, even if there's no bleeding associated with that, is a sign of clinically significant portal hypertension. And of course, if you get imaging and you see portosystemic collaterals, or if you see hepatofugal flow, that's another indication. But nowadays, we're seeing more use of non-invasive tests for the not only diagnosis of advanced liver disease, but also clinically significant portal hypertension. And these can be used as well to assess whether there is the presence of clinically significant portal hypertension. The most common modality is vibration-controlled transient elastography, usually in the form of a FibroScan. And the cutoff value for that is 15. So if you're seeing a patient with cirrhosis, you think they have cirrhosis, you get a FibroScan, you definitely see that they do have increased liver stiffness. When the levels are 15 or more, that's when you start to get concerned about having clinically significant portal hypertension, screening for it, and then intervening on it. So what can be done to reduce progression? Well, of course, treating the underlying etiology, reducing alcohol use and weight loss. And then the primary factor that we have right now for really preventing disease progression is the use of non-selective beta blockers. Now, there's been a lot of data about non-selective beta blockers, initially in the secondary prophylaxis phase, but also now in the primary prevention to reduce the risk of development of ascites, variceal bleeding, and also has an important effect on overall survival, both liver and non-liver related causes in patients with advanced liver disease. There has been more head-to-head data comparing the previous first-generation beta blockers, propranolol and nadolol, as compared to carvedilol. And due to its alpha-adrenergic blockage, there has been a lot of recommendations that on a head-to-head, it has a greater impact in reducing hepatic venous pressure gradient and reducing the risk of variceal bleeding and further decompensation and overall liver-related mortality. So basically, the important kind of summary when it comes to assessing your patient with chronic liver disease and portal hypertension is that almost every patient with chronic liver disease should be assessed either invasively or non-invasively for having clinically significant portal hypertension. If they do have clinically significant portal hypertension, primary prophylaxis to prevent the initial decompensation event is basically the mainstay of treatment, and that's usually with the initiation of beta blockade, especially carvedilol. You start off at a lower dose, about 6.25, and increase to 12.5 milligrams daily. As compared to other beta blockers, this is titrated based upon systolic blood pressure and not heart rate, so you want to keep the systolic blood pressure above 90 millimeters of mercury. And usually if this is okay and the patient is tolerating the medication, it could also obviate the need for screening endoscopy, just like patients who've had a TIPS procedure. They just won't have enough clinically significant portal hypertension to have varices, or especially varices that would bleed. And then the last important talk I want to talk about was updates on the HCV guidelines that we have available. So HCV has kind of lost a little bit of traction over the last couple of years because we're all familiar now with the DEA agents. We're still not doing the best job in terms of screening and linkage to care. So another important public service announcement is that all individuals now, regardless of the birth cohort, but every adult above the age of 18 should be screened for chronic hepatitis C and linked to care at least once in their life, or more frequently if they have risk factors. But the two important things were, one, well, it's difficult to get these patients into our clinic and then to follow them up. And then also this whole concept about hepatitis C treatment in the setting of hepatocellular carcinoma and how does that affect their outcomes, if it does at all. So one of the recent updates within the guidelines is that usually when you treat someone for chronic hepatitis C, you would treat them either for 8 to 12 weeks, get an end of treatment viral load to get an ETR or end of treatment response, and then a functional cure was defined as undetectable HCV RNA 12 weeks or 3 months after completion. But we did realize that a lot of these patients were lost to follow-up, almost more than half in most studies, and the studies have actually shown that if you were to get a viral load 4 weeks after the completion of treatment, that was almost as accurate as confirming SVR as compared to waiting another 2 months. So basically, not only are we now shortening, simplifying, and curtailing treatment, but also assessing SVR can be done pretty quickly, just 4 weeks after completion. Again, this is right now applying to a subset of patients with chronic hepatitis C, those who are who don't have basically cirrhosis and who are not treatment experienced. Just as it has moved to simplify those same population when they're initially being treated. But this is another opportunity for us to kind of streamline and make treatment easier for these individuals. And then when it comes to hepatitis C and HCC, initially when these DEAs came out, there were some published data about maybe the use of these DEA agents was associated with an increased incidence of hepatocellular carcinoma, so something to be mindful about. Studies afterwards really showed that it didn't really pan out, so we should not hold back treatment for these patients who had a history of hepatocellular carcinoma. Well, what about patients who have chronic hepatitis C cirrhosis and hepatocellular carcinoma? Number one, should their treatment modality be made more aggressive with the adding of ribavirin or prolonged treatment? The answer is no. You would treat them based upon their genotype as well as their hepatic synthetic function overall. And then, well, what about patients who are undergoing local regional therapy? Should there be any changes according to that? Because there's some question about, well, is local regional therapy either with a Y90 or a TACE procedure as effective in patients who are undergoing DA therapy, or the converse, that maybe sometimes in this perioperational period, do patients skip their doses, and does that affect their rate of cure over the point in time? But we kind of realize that that really doesn't play into fact. However, in certain individuals, when they're undergoing treatment, because of the immunological changes that can happen within the treatment for hepatocellular carcinoma, especially with histotripsy or local regional therapy, there's unclear data as if that would affect HCV treatment outcomes down the road. So it's reasonable as a grade 2 recommendation when the patient has hepatocellular carcinoma undergoing local regional therapy to kind of focus on that and maybe delaying hepatitis C treatment for a little bit. Not that we don't think it's gonna cure their hepatitis C, but to basically make it simpler for the patient so they can deal with their hepatocellular carcinoma, and then the patient can get treated afterwards. In addition, we're transplanting more patients with hepatocellular carcinoma. We're also using HCV donors a lot too. So those could be decisions that are incorporated within the transplant community as well when you're treating these individuals. But basically, you shouldn't shy away from treating the HCV infection in patients with cirrhosis and hepatocellular carcinoma, because they generally do pretty well, unless the goal is palliative in general. And in that situation, there would be no benefit in treating the hepatitis C. Right. Thank you.
I'm Fadi Antaki from Detroit. Question for Dr. Nadeau. You mentioned using NAC and acetylcysteine, and it's interesting because I remember when I was in training 20 years ago, for a while we tried to use it for everything, and then we went back to just using it for acetaminophen toxicity. And it looks like for alcohol liver disease, the guidelines say plus minus NAC. So how do you decide who gets it? And the second question is, do you ever use it alone if you're not comfortable using steroids for a contraindication?
All right, great, thank you. So I never use it alone. Obviously, we use NAC for acute liver failure, both Tylenol and non-Tylenol. We use NAC, but just NAC alone for alcohol-related hepatitis, I don't use. I have not, I think maybe one patient we used it in addition to steroids, but there was some question of concomitant liver injury otherwise. And so usually if I'm going to treat alcohol-related hepatitis, I'm only using prednisolone, but there is some data to suggest that the combo may be helpful. But in general, I stick to prednisolone alone. I don't know if my colleagues here have any other experience, but usually just prednisolone.
Yeah, agreed.
Hello, I'm Aditya. I'm one of the interns at Wayne State DMC. So I have a question for all hepatology and transplant people in general. In countries like India, we frequently encounter patients with liver diseases potentially linked to long-term use of traditional or Eastern medicines. They are often taken for like weight loss and general wellness. Many of these patients present with features resembling MASH, raising a question like, are they getting better, or this just traditional medication thus accelerating the bad effects that they already have because of MASH? So the question is there any data on transplant outcomes in these populations? And do they respond similarly to the patients with non-alcoholic liver disease post-transplant? Since we rarely see the patients in US, is there any data globally that is available? Thank you.
I think your question kind of is talking about, all right, transplant outcomes for patients with fatty liver disease, but maybe some who have used some form of herbal or dietary supplements for weight loss too. So I think you can answer that in the way when you talk about what are the transplant outcomes related to drug-induced liver injury, kind of in general. Because a lot of these, I think the best case example is, there's been a lot of DILI studies about people who have been transplanted for acute liver injury secondary to use of the herbal or dietary supplements for weight loss or bodybuilding. That kind of maybe is the closest subset of patients that I think look into that. Number one, because in the DILI network, that's really about the presentation, mostly with acute liver failure. It's like a really small subset of population, so it might not be, powered that much. But when you look at that, based upon data from the ALF study group, it is a rising cause of incidence of acute liver failure and need for transplantation in the US, particularly with weight loss supplements more than bodybuilding. Of course, it's no surprise that you see the weight loss supplements more common in female patients and bodybuilding supplements more common in men. Most of the people who developed liver failure needing transplantation in the bodybuilding supplement had cholestatic liver injury that did not recover within 6 months. Those that were weight loss were more hepatocellular injury and usually needed transplantation earlier on. In terms of their outcomes, I think they generally did pretty well, but I don't know of any long-term data to suggest, if there was any repeated use of herbal or dietary supplements. But I think the important, knowledge point would be is that the most common scenario in which we see most of these patients, if they have underlying alcoholic liver disease or fatty liver disease, but with that addition of a herbal or dietary supplement, is in the setting of acute liver injury or acute liver failure, which are not that many, but a good number of them need liver transplantation for survival, but their outcome seems to be pretty good.
Thank you.
Yeah, I agree. I think that ultimately speaking, there's two groups of patients here. One group is those who had drug-induced liver injury alone, and one group of patients who had drug-induced liver injury that led to an autoimmune response. And those are two really different types of patients. And some of those patients post-liver transplant will still develop an autoimmune response. If they've had some sort of autoimmune injury, they may have intrinsic autoimmune liver disease that could recur. So you're watchful for it. You're always checking liver enzymes after transplant. So they still tend to do really well. But those are obviously two different groups. And my rule is if they ever had drug-induced liver injury, they can never take anything over the counter without specifically talking to hepatology about it in that group of patients. And they can message us anytime. And they often do want to start something, and we just kind of have to hold them off.
Thank you so much.
Great talk. So I have a question for Dr. Hassan. In terms of the DDW study where they looked at GLP-1 and alcohol use disorders, just curious about how does it impact reduced use of alcohol? Is it central? Because the GLP-1 certainly acts centrally as well in terms of appetite suppression. So I don't know if they've looked at that to see if it's, from the patient's perspective, is it, less urge to use, or is it just similar urge, but it's more of a peripheral effect on something that's causing
That's a good
use?
question. I think the real answer is we don't know for sure. We certainly believe it's probably more of a propensity of a central effect, the same kind of a reward mechanism that it does for hunger and appetite suppression too. But there's a lot of interest in the microbiome too. And there's some data looking into, well, when these medicines work for weight loss and how weight loss affects the microbiome that can affect alcohol consumption. Because the other important thing is that we know that the microbiome kind of predicts in a way your risk of developing alcoholic hepatitis with metabolism, stuff like that too. So maybe it's an indirect pleiotropic effect with the weight loss, change of the microbiome changing. Maybe even if it doesn't change your alcohol intake pattern, but changes your susceptibility. Because we know the opposite or the converse happens, especially in female patients who undergo a bariatric procedure. For the same level of alcohol, they just seem to be a little bit more sensitive to developing alcoholic liver injury. And also more centrally, we also know that post-bariatric surgery, women tend to drink a little bit more too. So maybe that has a central effect. So I think there's an interplay between both central and peripheral effects, and we don't know that yet.
Thank you.
Hi, everyone. Thanks for the talk. I'm from the University of Toledo. My name's Sudhir. I'm a resident there. I had a question actually about portal pressure gradient measurement with EUS. And I was wondering if in clinical practice, you guys see that emerging as a alternative to the HVPG that's like currently is the gold standard. Is it something you see emerging and something hepatologists would be doing in their practice in the next 5-10 years?
I can have that. Yeah, so it's basically, there is an evolving field of endohepatology, right? Looking into advanced procedures, particularly in liver disease patients. And yes, there's been a lot, it's almost like a validated tool at this point in time. The thing is that it's still not made into the guidelines as a modality to measure, unless you're going in there and doing an EUS for maybe like sclerosing of gastric varices or something else like that. But there are certainly patients that I've referred for an EUS-guided liver biopsy for lesions that we've done percutaneously and never really got a good sample. And while they're in there, yes, they can get EUS-guided pressure measurements. The thing is though, and the same limitation that we've had in the past with other modalities of measuring portal hypertension is that, yes, there's a difference when your gradient is 0 to 5 and 5 to 10. But then above that, does it really matter that much over a period of time, the delta in the venous in the gradient? Now, if you're doing clinical studies, the clinical studies that led to the indication for beta blockers, right? They looked at, well, when you started propranolol, how much of a decrease you had in the venous gradient. But then down the road, how would that knowledge of knowing, well, what your pressure gradient is now or serial pressure measurements change your management at this point in time? Would I stop the beta blocker when I get my compensated cirrhotic, get his pressure gradient down to 8? Probably not. So yes, it is used in practice, but not as a standard of care for something that we would do on a frequent basis. And I don't know what the other panel members say.
We don't. I haven't really used that in practice much. I think, like Dr. Hassan was saying in his talk, I think the question is, what clinical scenario do you need it? And so if you're doing an EGD and you have varices, your answer's done, and you can start them on a beta blocker therapy. I use carvedilol more so than propranolol, as the studies have showed. But I guess the question is, in what scenario would you need it? And a lot of these patients, who I'm doing like transjugular portal pressure measurements and biopsies are patients who, particularly kidney transplant patients. I see a lot of these patients who were referred to me, does this person, do they have cirrhosis, number one? And then how high is their gradient? Or before a big surgery, maybe they need a Whipple, or maybe they need another big abdominal surgery. And the question is, risk stratifying them for decompensation and bleeding and those types of things. And those are the patients where I'll do more invasive monitoring for wedge pressures and hepatic venous pressure gradients. But in general, I just use the clinical picture, whether, with ultrasound, EGD, and labs, if they're thrombocytopenic and, they have a liver stiffness of 23 on a FibroScan, my answer's there. So doing an invasive procedure, another one on top of the info I already know, I just haven't used it in my practice.
Yeah, we use it similarly to risk stratify in situations where you're not able to determine based on FibroScan alone. So if somebody has a FibroScan, for instance, their KPA is greater than 15, you're trying to decide the safety of doing a kidney transplant or some other surgical practice. There's a lot of discussion about pre-surgical evaluation for these patients, and doing an EUS-guided measure of portal pressures or doing it through the advanced endoscopist is really becoming more common practice in that patient population, and we do it. But ultimately speaking, in terms of using it in daily practice, because we have FibroScan, we use that primarily to first stratify, and then if there's still questions remaining, we use that to help us out.
Thank you.
And as to whether hepatologists will be doing it in the future, I hope so. That'd be great. Now that every hepatologist seems to be doing transplant hepatology in their third year of gastroenterology, perhaps in the future they'll be able to do a fourth year in endoscopic, management, endohepatology as well.
Good morning. Thanks for your talks. So I'm Kaiser. I'm a first-year fellow at Henry Ford St. John. But we have a great relationship with our colleagues downtown, Dr. Jaffrey. So, if we need transplant evaluation, we'll do that. But there's kind of like a dilemma on the fellow side sometimes when we have the severe alcohol-associated hepatitis presentation when I'm evaluating as the first GI person, like the next morning, they're in the ICU and they've already been started on steroids, and this is not steroids for an ICU setting. This is for acute, severe alcohol-associated hepatitis. Oftentimes and it's maybe like a borderline MADRI, someone I wouldn't have started steroids on right away, and my attendings kind of support that decision, but it's already done, they've been starting it, and now we're kind of managing it. Have you guys open to all three of you, have you guys kind of faced that? How do you kind of manage that and, discuss with your colleagues in the intensivist care unit?
Yeah, I'll just stop it. I mean, to be honest with you, I'll make the executive decision the next day if I feel like it's not, number one, indicated. I mean, when you look at the studies, how long did it take them to start prednisolone? 6 to 7 days. So it's not, you have to start it right as soon as they hit the door, because remember, the contraindications are bleeding, infection. And so how do you know they don't have an infection within 6 hours? I mean, that's almost impossible, right? And so we always get cultures, we always do all these things and do an infectious workup. So I am not, first of all, I don't use prednisolone that often, but when I do, I use it very carefully, and I don't just start it right away. And so you have time. I think there is a misconception, like you're talking about, the person hits the door with alcohol hepatitis, oh, we got to treat them right now. That's certainly not the case, and it's not what the data shows. And so that's not how it was studied. And so if I feel strongly, I'll just stop it. And patients, oftentimes, they'll get transferred to us, and one of the first things we'll do is stop that until we can get a better evaluation of the patient. And so you have time. I think that's the thing to remember. So that's what I would say. And then the other thing, real quick, I know you really didn't ask this question, but the next thing is, a fellow conundrum that I see a lot, that I get called from the surrounding 8 hospitals in Cornwall East is, I know this patient's not a candidate for transplant, but I just want to go over the management. And so I said, well, how do you know? So it's not, it takes a whole team, really. I mean, some patients, yeah, I mean, they've been in and out of the hospital with alcohol use disorder, 1,000 times, but some patients, it takes a really thorough psychosocial evaluation and an evaluation by the entire team. So I always tell the fellows, if there's ever a question, just call. And we can always walk you through that and at least review the chart. And so we've transplanted many, many patients over the last couple of years who initially were not thought to be candidates and actually, turned out to be candidates. Because I think there's, again, that myth of 6 months sobriety and who is a candidate, who's not. I think that's still pretty unclear to fellows and people in training, and even to the hepatologists. Honestly, it's not cut and dry, and so it's a work in progress. I think, very case by case.
Yeah, I couldn't agree more. I think on both fronts. So, what we see a lot is that patients are put on steroids who already have kidney failure, kidney injury, which is obviously not the paradigm on which we're meant to be using it. If they've already had kidney injury, sort of that ship has sailed. Or, they have an active infection or another cause or etiology that's involved. But generally speaking, if you don't think you should have started it, then stopping it the next day is very logical in that situation. And I absolutely reflect the same comments about transplant. Transplant has changed entirely over the last year. I don't think people realize the degree to which it's changed, and we can talk a bit about the ways. But one of the ways is that everybody now across the nation over the last 5 years has become very open to transplanting patients with history of liver disease, even if they knew they had liver disease, even if they knew they had cirrhosis, and then they have their first decompensating event, that's still a candidate for transplant in many institutions. So having that discussion with a transplant institution for a patient that's getting sicker is very important in any of those circumstances as well.
Thank you so much. I absolutely agree too. I think that's a misconception I'm also facing when I'm talking to residents or even other attendings in our institution. So, we like to get them downtown soon and, get them at least a proper transplant hepatology evaluation instead of just that being done at our institution. The other thing is, I know the guidelines in ACG, you can use the MELD sodium or MADRI. Do you guys have a preference? I know there's MELD 3, and I'm often using that in my documentation. Do you guys have any information on which is preferred if you are kind of risk evaluating a severe alcohol-associated hepatitis?
Yeah. The initial data to prognosticate outcomes for patients with alcoholic hepatitis really was on the MADRI score. Newer data has shown that a MELD score above 20 is also actually pretty good in predicting that. And because that's kind of and again, these guys are sick, right? I mean, we always have this this intrinsic bias that, oh yes, alcohol related and stuff like that. But if their mortality is high, and if these patients pass away within 30, 90 days, it's not because of a seizure or something. They're dying because of their alcoholic liver disease that they've developed because of their drinking. So I think I utilize more of the MELD score because it kind of leads to maybe indirectly the idea that, look, we're not ruling out transplant right away, right? And that's what I kind of use.
All right, thank you so much.
All right, we'll go over here and then come back.
Good morning. I'm Avi, one of the residents at Henry Ford downtown. Thank you for the great talks. It's nice to hear about some of these new findings on the GLP-1s. One thing that I was thinking about is we do know that tirzepatide, a GLP-1 with the addition of a GIP, seems to have greater outcomes than the GLP alone. When looking at things like weight loss, it's almost a 10% increase in diabetes control. Do we find that we've seen some of these superiority as well in terms of the liver outcomes and maybe for the alcohol use disorder as well?
There is, I think, at least one study with tirzepatide looking at that and GLP-1s. I want to say it was published in February. I could be wrong about that, or it might have been 2018. I'm confusing the two studies. But there is a study that shows that it is helpful as well. And so the question is, do you use a combo? Do you use it alone? I don't think we know yet, but there is some data to suggest that is helpful in reducing alcohol use disorder in addition to the GLP-1.
Thank you.
Two quick management questions for you regarding the prednisolone therapy. There can be challenges getting the prednisolone. It's also sometimes cumbersome ordering it. And I've been told prednisone is reasonable. It's one extra step to making it active. You agree? And do you just convert 1-to-1? And then the second question, after the 28 days, do you taper or do you just shut off your steroid therapy?
So I just want to, the first part of your question, Rick, was that you have trouble getting prednisolone? Is that what you
Sometimes prednisolone, the way it's packaged, the way it can be a little more challenging to get that for patients. I think there might be a price difference too. I believe prednisone's just cheaper, and it may be because of my state.
Yeah.
But we just have an easier time getting prednisone once you discharge them.
Sure. Yeah, you can use an equivalent. I mean, obviously, when they have severe liver injury, it's always best to try to avoid that step that's metabolized in the liver to go to prednisone or prednisolone, but you can use the equivalent. I do taper, and so usually I do a pretty rapid taper.
Yeah.
And so a lot of times I'll do, they'll be on 40 milligrams of prednisolone for 28 days, and I'll do 30 for 3, 20 for 3, and then 10 for 3, and then off. I don't know how you guys practice, but I usually do a pretty rapid taper. Because these people are also high risk for infection as well, and so the quicker you can get them off, I think the better.
I could be wrong, but everywhere I've looked in the literature, nobody talks about the tapering. They just talk about the 28, 38 days of therapy, and then it's not really, there's no real guidance provided beyond that.
Yeah, it's a pretty rapid shift to just get somebody off of steroids all at once. So I tend to just cut it in half within a month, and then I try to taper it off a bit slower after that.
And the only thing I'd like to add is, I know there's a whole thing about prednisone and stuff. I can't remember the last time I started somebody in prednisone, but what I have been doing, I remember now all the patients that I actually start on either naltrexone or Camprol before they leave the hospital. Because when you look at it, 30, 90 days, it might not be the prednisolone or the prednisone that affects their outcomes, is whether they go back to drink it or not. So maybe more important conversation is, all right, when do you start naltrexone or Camprol in these patients? Are they ready? I mean, do you have to get like transplant or psych involved to see if they're like, engaging enough to try that? But management of their alcohol use disorder is probably the most important thing to affect.
But it is interesting now that we're transplanting a lot more of these patients, whether or not, it will aid survival in a different way, because survival to 28 days may have more meaning in this population now that we're trying to transplant them within 28 days in some cases.
Unless there's any other questions.
So, first of all, I want to thank the organizers for the invitation. This is my first time attending the meeting here. Several years back, I've been participating in some of the other CME events that we've done in Michigan, but for MIGI, this is the first time, so I really appreciate the invitation. And also great to share the podium with some of the colleagues that were in Michigan and now are at much better places and doing great things, and I'm really glad to have the chance to catch up. So if I can do the following, I think I would have done my task for the day. So if I can really convey to you 3 things today. Number 1 is that not all antibiotic resistance are the same. Number 2, not all PPIs are the same. And number 3, not all your refractory H. pylori patients are the same. So if you can keep that in mind, I would have done my job in the next 20 minutes of my talk. Thank you for the kind introduction. I've been in Michigan for 25 years. I did my fellowship there. I know a lot of colleagues have worked with me there. As a physician scientist, I spend 80% of my time thinking about why. I think about why diseases happen, but particularly 15 years ago, I started to get a lot of referral for refractory H. pylori. In fact, one particular referral says, help, I can't get rid of the HP. And so I started to kind of put on my thinking hat, thinking, well, why is it that patients are not responding? So I'll do the survey again when there's a little bit more people coming in, but how many people have currently in their practice HP patients that you can't get rid of their H. pylori? Can I have a show of hands? When I gave this talk 10, 15 years ago, only about 5% of the audience. Recently at DDW, I gave the same kind of survey. About half the room now have H. pylori patients that they can't get rid of. And I'll explain a little bit why. We all know antibiotic resistance is the problem, so how do we overcome these very tough to treat patients is hopefully part of what I'm hope to accomplish today. So these are my disclosures. Nothing here is relevant to what I'll be talking about and speaking about today. So the CME learning objectives, number 1 is I want to hopefully convey to you the impact of rising antibiotic resistance on treatment. Certainly over the last 10 years, we've seen guidelines from the ACG moving away from triple therapy to quadruple therapy. I'll explain to you a little bit more about not all quadruple therapy are the same, and that's part of the new guidelines. The second point is recognizing other factors that might be impacting the efficacy of H. pylori therapy, particularly acid, which I'll spend some time in my talk. And finally, understanding the rationale, right? We read the guideline all the time, but is it just going from one drug to another? Or is there some rationale to why we come up with these guidelines? And maybe every patient you approach should be a little different, other than what's the next drug, based on the guideline. So looking at the 2024 ACG guideline, one thing I want you to really focus on is that 3 out of the 4 treatment contain amoxicillin. Have you noticed that before? Now, is there a reason why amoxicillin is such a good drug? We're going to cover that. I'm sorry? It's not resistant. But there are other things that I will point out. So you're right. Unlike the other antibiotics, amoxicillin, you can use it again and again and again. The resistance rate is quite low. Unlike erythromycin, use it once, it's out. So kind of understanding not all resistance are the same. So, like I said, I asked a lot of questions about why. And the why patient fail antibiotic therapy really caused me to start to look at the anatomy of anti-H. pylori therapy. And there are several components to, like 3 components I think I want to focus on. And the first one is, we obviously know about antibiotic resistance, but beyond antibiotic resistance is what I hope to convey to you today. There's more to just resistance. And in fact, later I'll show you that even when we know which antibiotics we can use, 50% of patients fail with the Taylor therapy. So it's not just about resistance. You need to think about the dose of the antibiotics. So for those that are failing therapies, you should be moving away from BID amoxicillin. You shouldn't be using BID amoxicillin. It should be TID or more, even QID. What about gastric acid? How many people really focus on gastric acid as a very, very important factor? And why are we allowing our patients to continue to be drinking soda and be on a high acid diet while they're on therapy? If acid is such an important factor that we're trying to reduce, such that new drugs are being developed to more effectively target acid. So those are the things that I kind of use a more personalized approach to my patients. And finally, BMIs. How many people know that BMI actually affects the outcomes of the patient's treatment? And that's not currently being well studied, but based on my own practice and my own limited data, I can show you that BMI does affect the patient. Potentially, it's weight-based therapy that we should be moving towards instead of just going, everybody gets 250 QID, right? So hopefully those are the things that will come out at the end of my talk. So the reason we move away from erythromycin is before, 80% of the world are using erythromycin-based triple therapy. Why? It's easier to write, well tolerated. So that's why a lot of people were using erythromycin-based therapy. However, looking at the more recent trend, including in the US, you can see that the resistance rate is now on average over 20%, which means 1 out of 5 of the patients you treat is going to fail. And that's why I see more and more hands over the years that you are having patients that you can't really get rid of the H. pylori. The other thing that's of note, levofloxacin and metronidazole, the resistance actually also increasing, but what is not increasing is what? Like this gentleman said, the resistance rate is actually low for amoxicillin, for tetracycline, and for rifabutin. Data from Taiwan that really look at over the last decades or 2, how each of the treatments have fared. And one thing that will hopefully jump out is you see this line that comes down, it's erythromycin-based triple therapy. So erythromycin-based triple therapy, because of increasing rising resistance, its efficacy has also dropped. Another treatment is the sequential therapy. It also contains erythromycin therapy, also dropping. But those that don't contain erythromycin therapy have actually done quite well. Here, Bismuth standard quadruple therapy have been really steady over the years. High dose dual therapy and also Taylor therapy, meaning if you check for a resistance profile before you treat, it continues to be quite effective. Now, one thing, this is a very important slide. So it's from the same group that gathered the data on the last slide from Taiwan. What they have tried to understand is after 1 course of treatment that contains each of these antibiotics, if the patient failed to clear, what are their resistance profile? What you see here in gray is before treatment, where they sampled the stomach and isolated the bacteria to do their susceptibility profile. And then black is after failing that course of therapy. Unlike amoxicillin, clarithromycin, metronidazole, and levofloxacin, you see a lot of black bars on the resistance side, meaning after they fail one course, the resistance of the bacteria is quite high. However, look at amoxicillin on the top. Very few patients actually develop resistance after one course of treatment. So this is actually really strong data to suggest that clarithromycin, after one course, you should probably assume that they're resistant. Same thing with levofloxacin. Metronidazole, you're going to see higher resistance, but that's one where you can retreat because you can overcome the resistance, which I'll explain in the next slide. Amoxicillin, go at it. Use it again and again and again. Don't worry about resistance. The problem with amoxicillin is dosing. Why are we using BID? When most of the time, most of the treatment for other antibiotics, amoxicillin should be Q8. So the pharmacodynamics of the drugs, I think it's important. So why? So one of the things I hope to get across to you is not all resistance are the same. I just mentioned clarithromycin resistance is absolute. Why? Because of the mechanism, it binds to ribosomes. And once it binds, it's an absolute resistance. You can't overcome it by retreating with higher dose. Same thing with levofloxacin. It's a failure to block DNA replications. So once it's resistant, you can't overcome it. Metronidazole is different. Even when you have a resistant strain of metronidazole, you can overcome it because it blocks the redox system, which there are many. So at higher doses, you can actually overcome it. That's why the current guideline actually is suggesting that we optimize quadruple therapy. What's optimize mean? You shouldn't be using 250 QID. That's underdosing, which I will go over later. You should be using 500 TID as optimization. So that's one of the key changes with the 2024 guidelines. So hopefully you'll commit that to memory. About 15 years ago, I started, because of asking why are these patients coming in that are not responding to our great therapies, triple or quadruple? I started to track those patients by performing sensitivity in all those patients. So all those patients that fail, like basically we develop our in-house culture sensitivity so I can track all these patients. And after 15 years, this is sort of the summary of what I found. If you have a patient that failed a triple and a quadruple therapy, this is likely what their H. pylori resistance profile looked like. What do you notice? Clarithromycin, about 80% of the time, it is resistant. So if the patient has failed a clarithromycin-based treatment in the past, you can assume that that drug is out. Levofloxacin, about 50%, and metronidazole, 63%. But what you should also notice is the low rate of amoxicillin and tetracycline. These are patients that have already been treated with quadruple and triple therapy, so they have already been exposed to amoxicillin and tetracycline, and yet the resistance rate is low. We further follow those patients, use tailored therapy. So all those patients, we know exactly which antibiotics we could use, and we actually use a tailored approach. What was surprising is that of the patients that actually follow through, the response to tailored therapy is actually 50%, as you can see here, which means almost 50% of the patients, even when you know the antibiotic resistance pattern, continue to fail. So what is the other factors that we need to keep in mind? That's what I want to talk about next. So when we look at the sort of what are the factors that impact effective H. pylori therapy, I've already talked about optimized dose, right? The metronidazole needs to be optimized. Dosing interval, instead of BID amoxicillin, we should be using TID amoxicillin. We all know already, if the patient failed prior therapy, which are 7 to 10 days duration, you should be only using 14 days going forward. We know about patient tolerance, and which could be an issue, especially with high-dose quadruple therapy. But I could probably venture a guess that most of us know that acid is important, but really don't understand exactly why acid is important. And that's what I want to really focus on in the next several slides. Did you know that 5.5 is a really important pH we're trying to accomplish in H. pylori therapy? This is a study by the same group in Taiwan where they actually measure intragastric pH during therapy. And this is with clarithromycin-based therapy. That those in black dots are the patient that had a successful treatment outcomes. Those in white circles are those without. What did you notice? If the pH is less than 5.5, almost all of them fail. If the pH is above 5.5, most all of them are successful, which points to the fact that we need to really understand that we need to get the pH high. Hence my comment earlier about why are we letting our patients continue to be on a normal diet or a high acid diet. That could be something that I think would be helpful to have a conversation with the patient on why it is so important. What you're trying to accomplish here is really bring your pH above 5.5 and help them to understand the importance of diet during therapy. This is my own experience. We are conducting studies in Taiwan to really look at high acid diet versus low acid diet versus regular diet. And so stay tuned for those data to come. Now, one of the reasons why acid is very important in that last slide is the fact that low acid increases the degradation rate of amoxicillin at the surface of your stomach. So if you can bring the pH above 5.5, then the acid is not destroyed. It does not destroy the antibiotics, so therefore you have a higher concentration at the luminal surface where the H. pylori are found. Now, if you go from pH of 5.5 to pH of 7.5, there's a 10-fold increase in efficacy, meaning their MIC goes less, go lower, which means the therapy is more efficacious. But what's very interesting is that you see the same trend with clarithromycin, but not with metronidazole. So not all antibiotics are the same, right? Metronidazole is not affected by intragastric pH, whereas amoxicillin and clarithromycin and even levofloxacin are. Therefore, when you consider the effect of pH, the other thing that we know about the importance of a pH is that at higher pH is when the bacteria actually proliferate more. They grow more. And the effect of amoxicillin and clarithromycin actually requires the bacteria to be actively proliferating. Whereas metronidazole, you don't. So that's why the pH is very important to really focus on when you consider the pH effect on the antibiotics. Okay? So the effect of pH on amoxicillin and clarithromycin are very important, not as important as in sort of the quadruple therapies. That's one key point I want to point out. Now, I think considering the race of your patient is also very important. This is something that probably most of you have not heard, but it's in the literature that most of the patients in America, so Caucasian and Black Americans, actually are high metabolizers of PPIs, what we call extensive metabolizers. And you can see here, about 80 to 80% of the patients that we all manage here are actually hypermetabolizers, meaning you need to use a higher frequency of PPIs to be able to overcome the metabolisms. What was interesting is patient in Asia, Japan, and Chinese, and a lot of these data where we are seeing much higher rate of eradication, their poor metabolizers are actually higher, meaning those patients are a lot easier to achieve the pH of 5.5 than those of the patient that we treat. Hence, when we think about retreating our patients, we need to consider that most of our patients here are hypermetabolizers. We need to really be pushing the PPIs beyond BID sometimes. So for refractory patient, I only use TID for my PPIs. And then I'm going to talk about which PPIs in a few slides because not all PPIs are created equal. Now, this is a proof where if you use high-dose PPIs where you can achieve the 5.5, you really don't need clarithromycin. This is called the high-dose dual therapy approach. The high-dose dual therapy really, in this study published, which I was part of this, the rebeprazole, which is a second-generation PPI, a QID dosing, it's really high, right? Really high dose. And amoxicillin alone can achieve as high as 90%, which is even better than clarithromycin triple, as you can see in the comparison group, or levofloxacin comparison. Now, this is overseas data. Do we have any data in the US about how high dose dual therapy fare? Well, we do, because this is a study where they were looking at rifabutin-based triple therapy, and their comparator is actually high-dose dual therapy with omeprazole and amoxicillin at TID dosing. Doesn't do as well, right? What you see here is 5.7 with 5.7 and so in a range of about 50 to 60%, and that also has been in my practice. Now, so in America, just using TID amoxicillin or omeprazole is probably not going to get you a lot of success. And that's why in this particular trial, rifabutin was added. So rifabutin triple therapy in these, the trial here, they use amoxicillin TID with omeprazole TID, and then on top of that, they have rifabutin. Now, their rifabutin is smaller, it's actually lower dose, but broken into TID. Regimen. So it's a little bit different from just using rifabutin once a day or twice a day, which is the formulation that we can get access to. So there's a little bit more to this particular regimen that I think is different from what the standard rifabutin therapy that you might have already used. And I'm happy to answer those questions about what the difference is in terms of using the standard rifabutin that we're using versus this particular formulation of rifabutin-based. A few minutes left, but I'm almost end of my slides. The other thing I want to point out is the role of PPIs. You know there are first generation and second generation PPIs. The first generation PPIs, obviously omeprazole, but there are also lansoprazole and pantoprazole. And when David Graham did this analysis where they look at the efficacy of these PPIs with H. pylori treatment, one thing was very surprising is that sometimes you would think, oh, if they fail omeprazole, let me just add lansoprazole or pantoprazole. Actually, those two other PPIs don't do as well. So if you're going to use, if you can only use first generation PPIs, I would stick to omeprazole, and that's why that trial used omeprazole. However, my preference is to use second generation PPIs. The reason is it is not as affected by the CYP2C19 phenotype, the hypermetabolism, which most of our patients are. Therefore, use either Nexium or esomeprazole or rebeprazole if you want to use the high-dose dual therapy approach. But of course, now we have vonoprazan. And vonoprazan, obviously, it's shown to be more effective and it works a little faster because it not just binds to the active form of the PPIs, the proton pumps, it also binds to the inactive one. So it doesn't need to be timed to a meal, which could be a problem with some of our patients that are taking standard omeprazole. And its half-life is a little bit higher. So what are the data on this? Well, so in patients that we know will respond to amoxicillin and clarithromycin in sort of the clarithromycin approach, you can see that vonoprazan triple and dual therapy are not inferior. So this is a non-inferior trial. But if you look at the subgroup analysis, one thing that's very important to point out, sometimes just by looking at the table doesn't really help you realize that. The first thing I want you to realize is that vonoprazan triple is a little bit different from the dual triple because the vonoprazan dual has amoxicillin TID, whereas the triple has amoxicillin BID, which means if your patient is resistant to clarithromycin, vonoprazan triple actually is worse because only have the antibiotic that actually is working is actually amoxicillin BID. You might as well use the dual, which has the triple, has the amoxicillin TID, and that's what you see here. If the patient has if the patient has are susceptible to both amoxicillin and clarithromycin, the efficacies are quite similar with any of either standard triple or vonoprazan based. However, the group that really shows up to be significantly different is if the patient is resistant to clarithromycin, meaning if your patient has already failed clarithromycin triple, they're likely to be in this group. The efficacy of dual vonoprazan is actually a little bit better than triple vonoprazan. Interesting, right? But the reason is because the amoxicillin dual has, the vonoprazan dual has more amoxicillin than vonoprazan triple. So just want to point that out because that might not be as evident when you first think about triple versus quadruple, the dual therapy. So kind of a misnomer. Just a couple minutes left, but I just kind of want to share with you BMI is also important. In our study, we found that patients with higher BMI actually don't do as well. And do you know that metronidazole should actually be dosed by weight? It's 7.5 milligrams per kilogram. So really the standard dosing for 60 kilogram patients should be 450 QID. But a lot of patients that have gotten the standard dose have gotten the 250 QID, which is underdosing. And that's why this is the new guideline is really wanting us to now consider optimized therapy of the quadruple therapy, along with using the rifabutin triple, if that's not effective, and then consider PCAP-based therapy. One thing I wanted to point out here about levofloxacin is that there's a black box warning. So therefore, it should not be used unless you exhaust all other options. And therefore, I would actually, in my practice, switch instead of using levofloxacin, I would use high-dose dual therapy. And I would use a second-generation TID PPIs along with that. So I'm just gonna, because I'm out of time, I'm gonna leave you with this, how I approach a patient. If I get a referral from a physician about how do I get rid of H. pylori, I think of the ABCs of the questions that I ask. A, can I use amoxicillin? Is the patient allergic to amoxicillin? And is it a true allergy? By the way, most children with reactions or labeled allergic are not allergic as an adult. So it's important to kind of think about whether you should, I would send patients for allergy testing, and I've actually had some patients that were desensitized so I can use amoxicillin in my therapy. Number two, B for BMI. Higher BMI patient, consider more frequent dosing and higher doses, particularly with the guideline pushing for optimized metronidazole. And finally, what is the concentration of metronidazole? We definitely should be pushing 500 TID along with that. So with that, I will thank you. And again, just to summarize what I talked about, the importance of antibiotic resistance, not all antibiotic resistance are the same. You can retreat with amoxicillin, you can retreat with metronidazole, but not clarithromycin or levofloxacin. The importance of acid, and then finally, consider putting patients on low acid diet during therapy. Studies are to come, but that has currently been my practice. And so I will thank you for any questions later. Thanks.
Thank you for the kind introduction. And I'm glad to see we still have many folks still in the audience after this really amazing weekend. I will say there was a lot of great news and information shared with our audience. So I'm so happy to get invited back every year to participate in this annual event. I'm also very happy to see how much it's grown in the 4 years. So I'm very proud of the leadership that took over for me and Jamie. They've done a great job. And before I get started, one final point, I will tell you that in the summer, there aren't too many places that I'm going to leave coastal Maine to go to on a weekend. Traverse City is one of them. So, and the weather's been pretty nice. That's great. So with that, I will get started. I was asked to spend the next 20 minutes giving you an update on what I felt to be noteworthy presentations at DDW in the area of the EGD, in the area of the stomach and small bowel. I guess they messed up my title slide. It should have been, I'm sorry, esophagus and stomach. So I don't have any financial relationships to disclose. What I want to start with is a presentation that gave the results of the work done to standardize both the performance and the interpretation of what is known as FLIP or EndoFLIP. FLIP stands for Functional Lumen Imaging Probe. This is a balloon catheter with impedance sensors. It's placed in the esophagus at the time of endoscopy, and it assesses esophagogastric junction opening as well as esophageal body contractile activity. And it's oftentimes used as a complementary study to esophageal manometry in assessing esophageal motility. This was a working group of 19 experts in the field. Dallas seems to be a popular place for consensus because theirs is also called a Dallas consensus, much like the one on liver disease this morning. This working group had several goals. They wanted to optimize or standardize the approach to the EndoFLIP procedure, standardize the vocabulary that's used in the reports and in interpreting the results, and then finally update the motility classification scheme that could be garnered from the results. They used what's called a modified Delphi consensus process. This was multiple rounds of questions being answered by the members, with them also providing additional feedback. And they came up with 40 statements. And what I wanted to point out were the key outcomes that they shared at the DDW meeting. Number one, there were some key outcomes in terms of what the FLIP will provide. And that is, again, I mentioned the EGJ opening terminology. So they've refined this to really be one of three findings, either normal, inconclusive, or reduced. And then they also revised the contractile response of the esophageal body into one of 5 categories: spastic, disordered, normal, diminished, or absent. From those three, as well as 5 categorizations, you can then categorize the motility disorder into one of several categories. What was most notable is that a major motor disorder is unlikely to be the case if there is a normal FLIP classification. And I think this is important because I do esophageal manometries where I work, and quite a few patients cannot tolerate an esophageal manometry. And this may be a way to still assess esophageal motility without having to put them through a study that they cannot tolerate. I would also add that this, if you want more information on these statements, they just published in full manuscript form these consensus statements in Gastro this month. So you can go to Gastro and get the whole, all of the details on EndoFLIP. And basically the bottom line here was this, the results of their work essentially represents what is known as the Chicago classification for performing and interpreting high-resolution esophageal manometry. And if any of you are involved in this field, you'll understand that's sort of the Bible of how we interpret esophageal manometry. So now we have a similar way to perform and interpret EndoFLIP. And I'm going to switch around in terms of the studies I address here. So there's going to be switching gears from one to the other. So you just have to kind of ride on this train with me here. Next study that I wanted to discuss here was the safety as well as adherence and tolerance of a novel drug delivery system for eosinophilic esophagitis. So we are now well aware of the role of topical steroids in the treatment of eosinophilic esophagitis. In fact, I gave you on the slide here the algorithm. What I don't think we all appreciate is if you go to the document, you look at this document, you see PPIs and steroids are side by side. If you look more closely, you'll see that the quality of the evidence was low for PPIs and moderate for topical steroid therapy. And the recommendation is conditional for PPIs and strong for topical steroids. So topical steroids probably do have even a more important role, at least by the evidence, in the treatment of eosinophilic esophagitis. Our challenge is a delivery system that puts the steroid where it needs to be, in the esophagus and not elsewhere. Presently, we have the budesonide oral suspension that's available in the United States. There is an oral dispersible tablet that's out there, but it is not available as of yet in the United States. It's available in Europe, Australia, and Canada. This was a phase 2 study that was assessing both a targeted and longer-lasting steroid application to the esophageal mucosa. It's pretty neat technology. So this is a hard gelatin capsule that's weighted, and then they apply a microadhesive film around the capsule that's impregnated with a steroid, mometasone floate. The patient swallows the capsule, and the microfilm unrolls and attaches to the surface of the esophagus. It's a 25-centimeter length of film, and then it delivers the steroid to the esophageal wall. Their study actually was a randomized, double-blind, placebo-controlled study. They looked at 43 patients. This was in 13 European sites. 40 of the patients completed this 28-day study. I believe they swallowed the capsule once a day. And the tolerability was similar to a placebo. The treatment adherence was 100%. So one of the concerns they had is, can somebody with dysphagia swallow this capsule? Apparently there was no problem with the participants swallowing the capsule. And the adverse events were comparable in both treatment arms. So their conclusions here was that they've begun the development of a novel drug delivery system that's had a favorable safety and tolerability profile with high treatment adherence, regardless of there being underlying dysphagia, which again is commonly reported in eosinophilic esophagitis. Okay, so moving on. This was a study looking at the Watts 3D and comparing this to random forceps biopsy in Barrett's esophagus. This is actually an interim analysis on the diagnostic value of the Watts 3D in the Euro 2 study. Just a little bit of background. So Watts stands for Wide Area Transepithelial Sampling with 3D Dimensional Computer-Assisted Analysis. This is felt to increase the diagnostic yield of intestinal metaplasia and dysplasia in Barrett's, and they certainly have studies that show this. At present, though, there is no recommendation by the ACG, and there's a conditional recommendation of its use as an adjunct to biopsy by the ACGE. This study that is still underway was done to assess the clinical benefit of detecting high-grade dysplasia and esophageal adenocarcinoma. This was a longitudinal follow-up study on Watts 3D positive, random biopsy negative cases. So patients that were enrolled had to have either C2 or M4 Barrett's, that's by Prague criteria. So these are folks with either 2 centimeter of circumferential Barrett's, or they can have a tongue up to 4 centimeters from the Z-line or the GE junction. And they did not have any visible lesions. They were seen in 6 expert centers in the Netherlands. The biopsies were evaluated by expert pathologists, and the Watts 3D brushings were evaluated by expert cytopathologists. The findings were grouped as either non-dysplastic Barrett's, low-grade dysplasia, high-grade dysplasia, or esophageal adenocarcinoma. And then there was a 3-year follow-up of the enrolled patients. Their primary endpoints were concordance in detecting high-grade dysplasia as well as or esophageal adenocarcinoma between Watts 3D and random biopsies. And then second endpoint was progression of high-grade dysplasia or esophageal adenocarcinoma in a Watts 3D positive, biopsy negative during that 3 years of follow-up. So in the initial training phase, they realized there was some sample inadequacy with the Watts 3D, so there was some retraining, and that improved from a 40% to an 80% compliance. So there's a little bit of data difference initially with those first 183 cases. 290 of the 363 individuals that participated in this study had completed baseline results. What they found was there was no difference in the intention to diagnose either high-grade dysplasia or esophageal adenocarcinoma between Watts 3D and random biopsies. You can see the numbers there. There was also no difference in the post-training phase. And then finally, there was no detection of any dysplasia, and biopsy was actually superior compared to Watts 3D in terms of intention to diagnose or in the per protocol. And the numbers are a little bit small on the bottom of the slide, but you can see here, this is, for instance, this is negative Watts, and this was, so I want to make sure, it's very small, so I'm sorry, I can't see it either. But so this was Watts that was negative where the biopsy was positive. You see the numbers 55 and then vice versa here at 20. And for each of the three different categories, intention to diagnose, the post training, or in the per protocol, the biopsy was superior to the Watts 3D in identifying dysplasia. Going on a little bit more here, so Watts 3D did identify 13 cases of high-grade dysplasia and or esophageal adenocarcinoma that were negative on biopsy. They prospectively followed those 13 patients for a median of 19 months, and they all had a median of 3 subsequent EGDs. 10 developed either high-grade dysplasia or esophageal adenocarcinoma by biopsy, and they underwent curative endoscopic therapy. All of them did have low-grade dysplasia at baseline. 1 has completed the 3-year follow-up without progression, and 2 still remain under follow-up with no progression at this point. So their conclusions here was that Barrett's patients followed at an expert center demonstrate no clear adjunctive value of Watts 3D to biopsy in the detection of high-grade dysplasia or EAC. What I will say, I think the caveat here is these are expert centers. So if your practice is not an expert center, if you feel like you don't have a pathologist that's an expert pathologist or access to one, if you feel like you might benefit by this secondary mechanism of biopsy, I think you should still consider it. Again, this is data done at or acquired at an expert center. So that's the one caveat I'll give with this study. Moving on, I wanted to discuss this case in which they presented the safety and efficacy of TIF for acid reflux following EPOEM. So TIF stands for transoral incisionless fundoplication. I don't know if anybody in the audience is performing this. I do not. But this is an endoscopic technique that's designed to address GERD. And you can see on the cartoons here how it's used to shore up the GE junction. It's important to know that after esophageal per oral endoscopic myotomy or EPOEM, 20% actually develop reflux symptoms. Nearly 50% will be found to develop reflux esophagitis, and over half are on PPIs within 2 years of having their EPOEM performed. This was a meta-analysis that evaluated the safety and the efficacy of TIF for GERD following EPOEM. And their primary outcomes here were discontinuation of daily PPI therapy and improvement in esophagitis. Meta-analysis looked at 7 studies. This comprised 212 patients that developed GERD after their EPOEM. 59 of these patients underwent TIF. They were performed about 16 months after their EPOEM. The TIF procedure was 100% successful, and the pooled out adverse events roughly 14%. Following TIF, the quality of life scores dropped significantly. There was also a reduction in esophagitis by 73%, and a reduction in the need for twice daily dosing of PPIs by 97%. And almost 70% stopped PPI therapy completely. So bottom line here is TIF does represent a safe and effective therapy for GERD post-EPOEM, and this will improving both subjective symptoms as well as objective measures. So another reflux study, this was a database study that looked at how well anti-reflux surgery did keeping patients off of PPI therapy for their GERD versus endoscopic anti-reflux therapy. So they compared folks that underwent anti-reflux surgery, so either they had a fundoplication surgically or they had placement of a magnetic sphincter around the lower esophageal sphincter. And they compared this to patients that underwent a variety of endoscopic anti-reflux procedures, either an endoscopic fundoplication like TIF, or the Stretta procedure. They did matching for demographic and clinical differences, and their primary outcome was the time to reinitiation of anti-reflux medications, either that of H2RAs or PPIs. Secondary outcome measures also looked at medication reinition rates at 1, 3, 5, and 10-year intervals. They looked at a total of 65,000 patients that underwent either anti-reflux surgery, as well as 1,500 patients that underwent endoscopic anti-reflux procedures. They did see that those that underwent the surgery were more likely to be women and more likely to have a higher BMI. And the interesting findings here was time to reinitiating anti-reflux medication was twice as long for surgery versus the endoscopic procedures. Restarting the medication at 1 year was half of those folks that had an endoscopic procedure versus about a third of folks that had surgery. And I think what's most telling is at 10 years' time, roughly half of patients, even getting the anti-reflux surgery, were back on medication. So neither procedure really prevents patients from going back on medication at some point in their lives, I think is the important message here. So as I already stated, bottom line here, the anti-reflux surgery provides a significantly delayed reliance on anti-reflux medications compared to endoscopic procedures that are done for anti-reflux. However, the reinitiation of medication at 10 years is significant regardless of therapy. So important to counsel your patients on that. This is another interesting study that looked at the tailored treatment of functional dyspepsia with nortriptyline. Their aim here was to assess the efficacy of nortriptyline compared to placebo for functional dyspepsia, and this was based on the activity of the cytochrome P450 2DY with metabolic activity, which metabolizes nortriptyline. This was a double-blind, placebo-controlled trial of adults with functional dyspepsia based on Rome 4 criteria. They were recruited from 11 different hospitals in the Netherlands, and they took out any slow, intermediate, or ultra-rapid CYP2D6 metabolizers. This was a 12-week treatment of escalating nortriptyline. They started at 10, went up to 25, and eventually to 50 milligrams a day versus placebo. And the primary endpoint is much like these complex endpoints for DGBIs. This was a 30 or more % decrease in baseline in the weekly average composite score of epigastric pain, epigastric burning, early satiation, and postprandial fullness in 50% of the last 10 weeks of treatment. I know that's a mouthful to digest, but this is what it's required for these DGBIs. 69 of the 96 patients that participated were included in the intention to treat analysis, and they're pretty interesting findings here. The response rate for nortriptyline was 45% versus 58% for placebo. And the adverse events were relatively similar, although there was a statistically significant difference in them being lower in placebo. Interestingly, nortriptyline serum levels were higher in the responders, so clearly there's a dose effect here. And probably most importantly, belief in receiving the nortriptyline was higher than the belief in receiving the placebo in terms of their treatment response and the reporting of adverse events. So their conclusions here are, number one, nortriptyline is no more effective than placebo in functional dyspepsia in patients that are pre-selected based on their CYP2D6 status. Number two, and I think this is probably very important to me clinically, response to nortriptyline was related to serum levels. So clearly if you can get a patient onto a higher dose, they may be more effectively treated. And then probably most importantly, response rate was related to expectancy from therapy. So a lot of this is in many ways how we probably sell our therapy to these patients. I'm going to finish up with two more slides. This has to do with PCABs, which John already introduced at the end of his talk. This is a second PCAB, zastoprazone, which is currently being looked at for its use in the treatment of erosive esophagitis. It's already approved in South Korea. And as John already introduced, vonoprazan, we have presently approved here in the United States. It's approved for the treatment of erosive esophagitis. for both healing and maintenance. It's approved for the treatment of heartburn associated with non-erosive esophagitis, and it's also approved for the treatment of H. pylori, both as a triple and a dual therapy. As John pointed out with the cartoon I have on the slide here, the unique features of vonoprazan is it does not, and for the PCABs, is they do not require active acid pumps, and they don't require an acid milieu to be effective. So you can dose them regardless of when meals are, and they tend to have a more rapid onset and a longer lasting effect on pH management. So this was a phase 3 multi-center randomized double-blind study looking at 328 patients with confirmed gastric ulcer. And they were randomized to the zastoprasin versus lansoprazole and treated for up to 8 weeks. And as you can see, ulcer healing was 100% at 8 weeks on the PCAB versus 97% and lansoprazole. And incidence of adverse effects were comparable. So this demonstrated very similarly a non-inferiority to lansoprazole in the healing of gastric ulcers and a similar safety profile. And then I wanted to wrap up with this very interesting study. So this is looking at the risk of infectious gastroenteritis with short-term vonoprazan. I mean, we've seen a lot out there about the risks with PPIs. And we know probably one of the proven and well-known effects of chronic PPI use is the risk for enteric infections. So this study was a global database analysis using the TriNetX through November of 23. It looked at over 9,000 patients that have taken vonoprazan and had not been on a PPI in the year prior. And they compared this to 762,000 folks taking a PPI who had never been on vonoprazan. It's interesting, it's worth pointing out that those that were on vonoprazan were older, tended to be male, were more likely to have GERD, and were more likely to be treated for H. pylori. And what they found was that the risk of developing infectious gastroenteritis in the worldwide population was nearly 3 times higher with vonoprazan than PPIs. And if you looked just at the US population, that's the second line down, about 5 times more likely to develop infectious gastroenteritis versus with PPIs. So I think it does give us something to think about. I mean, clearly they do a great job reducing the pH, but I think we need to counsel patients on being careful when they're on this therapy because they may be at higher risk for gastroenteritis. And that's it.
And I'd be happy to kick it off unless somebody else has a question. Yeah, go ahead.
Hi, I got a question about the H. pylori treatment. Any word on doxycycline instead of tetracycline? It's usually tough to get tetracycline. Sometimes I had difficulty finding it in the pharmacy. And is it okay to switch with doxycycline? And what dose would you use?
Yes, thank you for that question. And it certainly has been a problem with the availability of tetracycline. And no, doxycycline as a substitute is not a great choice. And so I would, instead of using that quadruple therapy, use some other options, either rifapentine-based triple therapy or the vonoprazan-based therapy. So doxycycline is not a good substitute for tetracycline.
Another question, if I may. And we don't see any regimens with because we know amoxicillin is one of the better antibiotics to use. We don't see any comboing or putting amoxi in a combo with tetracycline or metronidazole. Is this an okay regimen to use in patients with drug resistance or in patients who failed, let's say, triple therapy before and trying to still use amoxicillin for whatever reason?
Can you repeat that first part? I'm sorry.
Is it okay to use amoxi with tetracycline or metronidazole in combo for H. pylori treatment? Because none of the regimens I'm aware of uses that.
Yeah, so there's a reason for that. So there's some earlier data that tetracycline and amoxicillin, in fact, the combo actually did worse than amoxicillin alone or tetracycline alone. So somehow those two drugs together is not a good combination. But you certainly could switch out tetracycline for amoxicillin as a potential alternative.
Is amoxi and metronidazole okay?
Yeah.
One last question. But H. pylori culture, I tried to culture it before. It never grew. Any thoughts about that?
So yeah, so if you do H. pylori culture, you have to culture in-house. The problem is the delivery to the lab. I know you can do send out, and usually the problem is that H. pylori would die en route to the lab. So we in Michigan were successful in creating our own culture and protocol. It's because we deliver it to the lab within an hour. So there are other media, transport media that you can use, but certainly I think that is something of a limiting step for being able to successfully culture. You know, the fecal, now there's the NGS fecal culture. Just a short of how many people are using the fecal culture in their practice? Okay, you are, great. I mean, certainly it's available, but whether it's accessible, whether insurance is covering it is still a limitation. And so, but that's something in the future that we should be using tailored therapy so that we know what best antibiotic to use. But at the moment, I think most of us are doing empiric therapy. And so hopefully some of the things I talked about choosing which antibiotic will be helpful for your patients.
Thank you.
Thank you.
Kind of reviewing some of the two studies you said about TIF and then the one that followed it, it kind of suggests that even if you do the TIF afterwards, it's probably not going to be as long lasting as like a surgical repair after, but obviously it's postponed. So it's an interesting paradigm between the two that no matter what you do endoscopically, it may not be as long lasting as a surgical fix to the problem. So just comment on that. And the other question is, do you see that flip probably in someone coming with dysphagia now, if you have EndoFlip available, rather than booking them for a manometry separately, you would take a measurement right when you do your initial endoscopy?
Yeah, so I'm in the process of trying to acquire the flip technology. So it's on the docket to possibly be purchased by my facility in the coming fiscal year. But what I'm running into is we have about I'd say roughly 20% of our patients can't tolerate the esophageal manometric catheter placement. So if there is somebody being referred for, primarily it's dysphagia, that didn't have an explanation on an initial EGD with biopsy, and they can't tolerate that manometry, what my plan will be is to perform a subsequent EGD and perform EndoFlip at the time of endoscopy, and use this now standardized, not only the protocol, but also the way to interpret the findings to diagnose these patients. And I think the nice thing that I think is probably going to evolve from this is if the EndoFlip is completely normal in terms of EG junction opening and esophageal body response to the impedance, you could probably not have to worry about an esophageal manometer. You can safely and very completely say to that patient, they don't have a motility disorder to explain their dysphagia. So I think that's going to be one of the key uses for it. Did I answer your question? You asked if it should be done with an EGD. It should not be done in isolation. The
question was partially also
yeah, this isn't going to replace manometry, and I don't think it ever will personally. But I think it will have a growing role for patients that can't tolerate that procedure. So I don't know if any of you do esophageal manometries, you order them, but they're really hard studies for patients to tolerate. And I mean, they're lying on their back with a catheter down their throat, through their nose, and they're drinking water. I mean, it's not everyone can tolerate that. But this study, they'll be asleep, and it can be done during the time of an endoscopy. So I think I think this is going to allow it to have maybe a bigger role in our workup of dysphagia for patients that either refuse or can't tolerate a manometry.
So I'll add my 2 cents as well. You're absolutely right. So right now we don't have a monodiagnostic tool for esophageal motility disorders. So even when we get a manometry, and it's a good manometry, if there's EGJ outflow obstruction, for example, we say provided supportive studies like a time barium esophagram or an EndoFlip kind of confer with that, right? But what was really exciting about the study that you showed was that manometry fundamentally is just not offered everywhere. And it's really expensive. It's about 6 figures to get the whole system in place. In addition to that, you have to have 1 to 2 nurses to actually do the studies, conduct them. You might need to have an additional scheduler to schedule them, and then you need to have an attending usually sign off on them, right? But with EndoFlip, you can do it during an endoscopy. For all of us that do them, I do them, it takes like an additional 5 to 8 minutes. Certainly the second generation EndoFlip is much more user-friendly than the first generation one. And so it's kind of nice that you don't need a whole lab, you kind of don't need a nurse, you don't need all of those extra things, and from a patient tolerability standpoint, it's definitely better. But there are things on a manometry that are simply not available with an EndoFlip. The physiology of the upper esophageal sphincter, we can't see impedance, and then there are small nuances that we see in esophageal manometry that you simply can't replicate with an EndoFlip. That being said, I think it's a really solid adjunct study, especially in conjunction with manometry and time barium esophagram. And of course, nothing can replace a diagnostic endoscopy.
The other thing about these motility studies, like I said, if you don't read them, you probably don't appreciate this, but they very rarely look perfect. I mean, there's a lot of nuance into reading them. And as I said, I would imagine, I haven't done EndoFlip yet, so I don't know, but this new protocol and classification should really objectify it and simplify it and make it far more clinically relevant for its use in patients with dysphagia. So.
I do love the idea, though, of having a classification system we can all now adhere to, kind of like the London classification for anorectal or the Chicago classification for esophageal. It's nice that we are standardizing the way that we are doing things and reporting things as well. So that's really exciting. Any other questions before I launch into mine? Okay, so I want to talk a little bit about TIF, because I think that if you have a young type 2 achalasia patient who's like 18 years old or in their early 20s, a lot of times we will shift those patients over to our surgeons to do a Heller with a partial fundoplication. And so, we always say, because a lot of patients actually prefer poems when you kind of conceptually talk about it over a full-on a surgical myotomy. So it's nice to see that there's finally some data about TIFs that are coming out. I think what my questions would be, how do you determine reflux, right? So do you determine it via follow-up endoscopy with the presence of esophagitis? Do you subject those people to a Bravo? Do you subject them to a 24-hour pH with impedance? So how do you define it? When do you do it, right? So I saw in here it was 16 months, but would it be appropriate to offer it a little earlier, right? To kind of prevent future damage. So we recently had a case of low-grade dysplasia in Barrett's that, we took GE junction biopsies prior to POEM, they weren't there. And of course, there could have been a sampling error, I guess, but this kind of came on about a year after the POEM. So we're going to be reporting that. But I guess, what is the sweet spot with regards to when to offer a TIF is also really interesting. How to diagnose this esophagitis, what to do with the PPIs still. So I think there's still a lot of unknowns, but hopefully this is kind of the start of gathering a lot of data. And then similarly, how long do these last? Because we are seeing a lot of patients who have undergone Hellers with partial fundoplications who we then see with recurrent dysphagia. And is it kind of an incomplete myotomy? Is it a blown out distal esophagus? Or is it too tight of a wrap? So then we end up doing a posterior POEM on those patients post fundoplication, and it usually helps, but is that going to be a problem with TIF as well? Kind of don't know.
Well, I would say our center doesn't perform TIF, so there isn't actually anybody in our center doing it. We do have a hospital not too far away that does, their gastroenterologist is doing a lot of TIFs. I have communication with him, and I might reach out to him just to see what kind of data he has on this. Because I honestly don't know for a patient who's had an EPOEM, a young patient who's had an EPOEM for achalasia who is, they're failing medical therapy for their GERD, or they don't want to take medical therapy. Is this something that's a reasonable thing to offer versus having to meet with a surgeon and talk about a fundoplication?
Yeah.
So I think this work that was presented at DDW, I think it opens up the door now. We've definitely got some convincing evidence that this is a viable option for a patient who's had an EPOEM done. It's not a huge population of folks with EPOEM, but
Yeah,
So
it's interesting. So now my
More to
final,
come, I think.
more to come for sure. So my final question is for Dr. Ko. So what do you do with a patient who you start on therapy who can't tolerate it? So I think we've all gotten those My Chart messages 5-6 days into therapy saying, Doc, I'm so sick. I'm having terrible diarrhea. I'm nauseous. I just can't tolerate it. Do you, and I'm going to give you 3 options, and then you can add options if you want. Do you, number 1, stop therapy, keep your fingers crossed, check for eradication a couple weeks later? Do you, number 2, try to treat them symptomatically, Band-Aid some of these symptoms, Zofran, et cetera? Or number 3, do you pivot to a different therapy and complete the actual, do you complete therapy and then check for eradication after that? Or is there another option that I'm not thinking about?
No, thank you for the question, and certainly, compliance, because of so generally it's the quadruple therapy, the metronidazole is the harshest of the antibiotics that we're going to experience. So you're going to run into more of that question with quadruple therapy, especially with the new guideline pushing for optimized 500 TID to QID. So one thing I tell the patient, I educate them about the biology of H. pylori is once they've seen the bacteria, they go the rate of mutation in the stomach is very high. So if you stop the therapy early, there's a high chance that they may become resistant, as we saw. So my approach has always been really try to support them, with antiemetics, and really just guide them through, at least 10 days. I know you may not be able to tolerate 14, but let's at least get to that 10-day mark, and I'll support you and see what you can do to get through it. So yeah, stopping therapy early is really a bad idea. I think that's something we need to talk to the patient beforehand too. I think that education really helps the patient understand that HP does mutate very quickly if you give them a chance. So those are my answers.
Okay, great. Are there any other questions before we wrap up?
And probably remind them not to drink alcohol when they're on that 14-day course of quad therapy because of the alcohol interaction with the metronidazole, and that
That's
could
a
be
big
driving
one.
a lot of their symptoms.
Yeah.
So I'm very specific about counseling on that too.
Excellent point. Well, thank you both so much.
I have one question.
Oh, one more
for H.
question,
pylori. So if you were trying to maximize efficacy and tolerability in one drug and right on this day, cost not a thing, which one would it be?
High-dose fluid therapy. If cost is not a thing, I think the rifabutin, which has the high-dose amoxicillin, that would be my choice of minimizing, tolerance, because it's a TID dosing as opposed to quadruple therapy. And then outside of that, I think high-dose fluid therapy is something that we haven't really used as much, but it's really been used in Asia quite a bit, mainly because
with vonaprazan, correct? With Voquezna?
With vonaprazan, but with the PPI is rabeprazole. It's a second generation PPI. So I think that's that. But with vonaprazan now you can use dual quite effectively.
Thank you.
Thank you.
Great pleasure to be here. Thanks for staying to the very last minute here. Today I'd like to talk to you about something that you're going to be needing tomorrow or any day that you're on call. Whether you're an advanced endoscopist or a general, you cannot escape call for the most part. And so bleeders will find you if you don't find them. So every slide that I've included in this deck is trying to teach you something that you don't already know standardly through your standard regular fellowship or general treatment of these GI bleeds. So hopefully you can learn something today. The first thing I'd like to talk to you about is the pregame. Okay, this is kind of the boring part, but it's perhaps one of the most important parts. We're going to talk about some guideline risk stratifications, resuscitation, and timing. Whenever I see a patient, the very first thing that I do is I shake their hand, and I'm a little creepy when I shake their hand. I hold their elbow. I've once met Bill Clinton before. He shakes people's hand like this. He'll shake your hand like this, and he'll kind of massage your elbow. You like it, but you don't like it. It's weird. And I kind of learned to do that. That way I can kind of feel their skin. And if it's cold and clammy and they look pale, they're peripherally clamped and I'm worried that they're actively bleeding. The next thing that I do is I hit the bed and I put their head down in a Trendelenburg position. That's a poor man's volume challenge. Then I hit the button to check their vitals again. And it clicks. And if their heart rate and their blood pressure has improved by me performing a Trendelenburg position for them, then they're not yet ready for endoscopy. They're still volume down, so you need to keep resuscitating them. How do I resuscitate them? I use 2 large bore or 3 large bore or 4 large bore. There's no limit to the number of large bore IVs you can put in a patient. They're much better than PICC lines. I remember when I was a resident, I loved PICC lines because I felt like I always had IV access, but they're terrible for resuscitation. They're miserable. They're long and they're skinny and it doesn't work very well. Okay, so I always order 2 liters lactated ringer bolus, and then I write in there until PRBCs arrive, and then we switch it out, right? I use a restrictive red blood cell transfusion strategy that aims for a target hemoglobin between 7 and 9. We know that overtransfusion is associated with poor outcomes. But remember, when you give that strategy, that means that you need to be between 7 and 9 at the time of endoscopy. So if their hemoglobin is 6 and your creepy Bill Clinton handshake reveals to them that they may be actively bleeding, and the Trendelenburg says that their volume low, well, you may not need to just give 1 unit, you may need to give 3. Right, so that by the time the endoscopy starts and anesthesia insists that you recheck the CBC, that it's not 6.9 and then you're bringing in the on-call team at 5 p.m. We've all been there, right? So anticipate. Now, a higher target red hemoglobin target should be offered, not offered, but mandated, in my opinion, to people who have ischemic cardiovascular disease. Because I believe that in the modern era, given the tools that we have, very few people should be dying from hemorrhagic shock from upper GI bleeding, especially if you're located in a relatively metropolitan area that has interventional radiology backup. But the people that do die, in my experience, are people who have coronary artery disease. And they don't die from hemorrhagic shock. They die from ischemic changes in the heart. They die from myocardial infarction. Okay, they get demand ischemia, they start getting chest pain, the troponin's going up, they're still vomiting blood because they're on 3 blood thinners, and then they end up dying from an acute MI. That's been my experience and many people's shared experiences. And this is all happening now in the modern era where people are living longer and people are getting more and more blood thinners. Yeah. So for those people, I target a hemoglobin of 10, actually. Oh, this thing about this green 18, blue 22. When I was in college, I played football at Harvard, and the quarterback was a guy named Ryan Fitzpatrick. He's like a famous journeyman quarterback. And I was on the practice squad. I wasn't very good, but he would always say before he hiked the ball, green 18, blue 22, hut, hut. And I'd always remember that. I'd say to myself, green 18, blue 22, when I looked at a patient's IV. Because if you look at the color of the IV hub, if it's green, that's green 18, that's good. If it's blue, that's blue 22, that sucks. You don't want blue 22. The other one's the other one. The pink one's always 20 gauge. But you want as many green 18s as you can. So shake their hand like a creeper, see if they're cold and clammy, hit the Trendelenburg, and look at their IV. All that happens between the wrist and the elbow. Now, remember that people get BU and creatinine ratios that increase in upper GI bleeding for 2 separate reasons. One, pre-renal azotemia. Right? They get volume depleted and the BUN goes up, as we all remember from physiology. But the second thing is that they're getting a huge protein load in the form of their own blood, right? And digestion and absorption occurs in the stomach, duodenum, and proximal jejunum when it comes to protein digestion and absorption. So interestingly, if someone is having small bowel bleeding, that's past the ligament of Treitz or far beyond the ligament of Treitz, let's say in the deep small bowel, you won't see a significant rise in their BUN creatinine ratio except for the pre-renal azotemia component because they're not absorbing and digesting a protein meal. So just a little thing, if you see black stool and someone who's got a lot of blood thinners and their BUN creatinine ratio is not up, but you're quite sure that they're bleeding, think about small bowel bleeding. The GBS is not a useful score in practical terms. It has a million different numbers that you have to remember. It's excellent for research and it's excellent for predicting mortality because of its granular nature. The AIM-65 is a little bit better, but also it requires 5 numbers. It's a little bit more practical. I don't think anyone's actually using these, and I don't see anyone writing notes about AIM-65 scores in the emergency room. But I'll tell you a triage score that you are using. You just don't know. Okay, and it's called the Harbinger triage score. It contains only 3 variables. If the patient is not taking a PPI, they get 1 point. If the patient has a shock index greater than 1, which means that their heart rate is greater than their systolic blood pressure, then they get 1 point. If their BU and creatinine ratio is greater than 30, they get 1 point. This score outperforms the GBS and the AIM-65 in the prediction not of mortality, but in the prediction of the presence of high-risk stigmata that will require endoscopic hemostasis. And when it's 4 p.m. and your nurse manager is asking you why we're doing this GI bleed tonight, you can tell her because I use this score. The next question she's gonna ask is, are we just taking a look-see or we're gonna actually do something tonight, right? That's a very important question. She's asking whether or not you're gonna see a clean base ulcer tonight, which looks the same at 9 p.m. as it does at 9 a.m., or you're gonna see high-risk stigmata, and by doing something tonight, you're making a difference in the patient's life, right? That's really what she's asking, and that's really what this triage score is gonna predict for you. So if the score is 0, they can go home. 1 requires an admission and observation. 2, greater than 2, and then particularly 3, you'll be doing something tonight, not just a look-see, okay? Now, in terms of the timing of endoscopy, all the multi-society guidelines recommend early endoscopy within 24 hours, right, after resuscitation. Very early endoscopy, as defined as less than 12 hours, should be considered in the following 3 circumstances. When the patient remains hemodynamically unstable despite resuscitation, if they're having active in-hospital hematemesis or nasogastric aspirate, frank blood, okay? Or they cannot stop their antithrombotic therapy for whatever reason. These are oftentimes patients on advanced cardiac support, ECMO, LVAD, these type of things. They simply can't stop it or else their devices will clot and they'll perish. So for those type of patients, you can push the timing shorter, okay? Now, I didn't used to believe this, but now I do. Performing super urgent or emergent endoscopy for active GI bleeding is probably a mistake. I used to think that GI bleeding was like customer service, like a pizza delivery. The faster you get it, the better off you are, right? And for many, many years as a hospitalist, I believed that to be to my core, and I defined my own value on how quickly I could get someone from like what is it called, like door to cath time, like door to scope time, right? I thought like, oh yeah, got him in 3 hours. But the research shows that that's a mistake, that those people actually do worse. And the reason is because 2 reasons. One, they're probably under-resuscitated, right? They're under-resuscitated. Like I get to them a hemoglobin of 7.0 and I push anesthesia, I'm like, it's okay, 7.0. And I push and I do the procedure and I save the day and I think it's great. But I finally got burnt. And I finally understood why the research shows that that's not true. Because I got to 7.0, the person had coronary artery disease, there was an adherent clot, I dislodged it, it erupted, a GDA just erupted, and I couldn't control it. Now the hemoglobin was 6 and falling. And then the person started to get chest pain, the troponin got up, the tracers showed ST elevation MI, they were in deep trouble, right? And that person did very poorly, right? And it's because I rushed. And I didn't allow them to have what I call the medical tourniquet in GI bleeding, and that's PPI therapy. I didn't allow them to have the miracle of IV PPI therapy to help stabilize their clot further, and I rushed it. And I encourage you not to do the same mistake. And if your IM hospitalists push you faster, you can show them the evidence, and you can tell them that Dr. Bloodengut's screwed one up, so you're not gonna make the same mistake. All right, now to the actual endoscopy. There are 3 remaining pain points in modern endoscopy as it relates to upper GI bleeding: poor visualization, difficult positions, and refractory bleeding. I'm going to demonstrate to you through 10 cases very rapidly all the tips and tricks for these 3 problems. And through it, I'm going to go through every single tool in our armamentarium that exists in modern day. The first one is difficult visualization. I'm going to teach you how to augment suction, reposition the patient, and utilize the clear cap. This is a massive blood clot in the proximal stomach. This remains a modern day problem because our endoscopes have gotten so good at visualization, but their mouths remain the same size, 3.7 millimeters for therapeutic, and it hasn't gotten any better, right? So you're suctioning, it clogs, you can't clear this, what do? Back in the day, they used to pass these big evacuator tubes or E-wall tubes blind. They weren't that effective, to be honest with you. Now, there is a scope that It has a 6 millimeter channel. It's called the GIF XTQ160 from Olympus. Unfortunately, it's been discontinued for unclear reasons, and they're no longer supporting it, so you can't get it, right? But you do need to switch to a therapeutic gastroscope no matter what. The second thing you can do is if you have a big clot, you can disconnect or borrow the suction from the back of your scope and directly plug it into the biopsy forceps. That bypasses half the length of the scope and therefore doubles the power of your suction. Another way to boost the suction is you can connect 2 vacutainer pumps through an auxiliary connection to another pump. You see that? One connecting to the other. If you turn those to max suction, you'll also double the power of your suction. If that doesn't work, you can reduce the particle size or viscosity by chopping up these blood clots using a cold snare. It's pretty ghetto, I'm not gonna lie, but after about 5 minutes, it does work, okay? 5 minutes in upper GI bleeding is eternity, I understand. But in great times of desperation, you can use this, right? The other thing that you can use is to convert the Pathfinder flexible rigidizing overtube to a ginormous suction hose. I actually can say that I helped invent this. You can see, you convert the overtube into a huge vacuum attachment, and it can suction fluid and that, I think that's boba or something at the bottom there, like tapioca pearls. It can really do a great job of evacuating quite quickly. If you already have the existing Pathfinder tube, this is just an attachment on the back. It's a 3D printed attachment. It's very cheap. How it works is basically it suctions in the annular gap between the flexible overtube and the scope itself. It has its own dedicated suction tubing. I guarantee you this, you won't encounter a clot that this can't evacuate. I use this almost on a weekly basis. It doesn't work for food, I've tried. Case 1, arterial bleeding unto itself. This is a large polypectomy. I know that there's bleeding there, but unfortunately, the bleeding is torrential and uncontrollable even with a clear cap. Okay, that's pretty bad. Okay, the problem, of course, here is that the blood is pooling directly over its own bleeding point. And in this circumstances, it's not about clearing clots and anything. In this circumstance, you need to change the vector of gravity. So turn the patient. You see that? I can't control this because I can't see the source. Which way do you turn them? Any way. Just not this way. Any way. Right lateral, left lateral, upside down, Trendelenburg, it doesn't matter. Change the vector of gravity. That way, now you can pool the blood somewhere else. Then you can pass my favorite fastest emergency tool, which is the hot biopsy forceps, and you can perform 60 watts soft coagulation and avert truly a terrible disaster there. Okay, why do I like the hot biopsy forceps? We'll get to that in a second, but because they cost $20 and you can throw them down the instrument at rapid speed because they have markers on them, right? And they grasp a large amount of tissue. If you need to move the blood clots out of the fundus, put the person in the right lateral position. Now that's extremely difficult to scope in, right? It's very ergonomically unsafe. But for that brief period of time, you can move the stomach contents distally. You can also put the patient in a very severe head up position, right? Like as you can see here. You can displace the blood, not as well as the right lateral position, but enough to clear the proximal stomach. And when I mean a severe head up, I'm talking about 45 to 60 degrees head up. You can move that blood clot down temporarily. You can't clear it, but you can move it. You can move it so that you can see 2 potential bleeding sources. One, obviously gastric fundal varices bleed up there, but also the classic doulophore in the proximal stomach. This left lateral semi-recumbent position, which is in the upper, where you lift their head up significantly, you can see in this nice study that was done in a small hospital in India, how effective it is at cleaning or clearing the proximal stomach and allowing the visualization of what they treat a lot in India is gastric varices. This was a beautiful study. It was so well done that the president of the ESGE decided to write his own editorial about this because he used it so frequently. This was like a little no-name hospital in India. It's a profoundly good tool. Okay. Now, in terms of monopolar hemostatic forceps, many people know that of these. They're like coag graspers, people call them. There's other ones that are created by other companies. But right there, the one in the green, that's my favorite one, hot biopsy forceps. Now, I know that some of the senior guys in the room are like, well, we don't use those anymore. Yeah, we don't use them for biopsies. They're terrible for biopsies. But they're excellent hemostatic tools. Now, back in the day, they were a little dangerous because our ESGs only had one, the blue pedal only did one thing. Strong forced coagulation, just burn, burn, burn. But now we have much more sophisticated electrosurgical generators that can perform soft coagulation. Okay, so I think these devices actually are very, very safe. There's other devices that are made by other companies. I'm not really allowed to say their names or whatever, I guess, but we can talk offline. In Japan, they performed a randomized controlled trial of patients who had peptic ulcer disease with high-risk stigmata, and they were randomized to either hemostatic forceps or clips. And in fact, in Japan, they don't use bipolar probe very much, if not at all. So they typically rely on monopolar forceps. And the hemostatic forceps were superior in every way. Initial hemostatic success, recurrent bleeding, duration of procedure, length of stay, and there was less adverse events. So even though you may not be using this, I highly consider you start practicing. It's an excellent tool. Here is a case of a duodenal artery that's ulcer that's arterially bleeding. And here I have a clear cap that I'm using to tamponade this big blood vessel. You can see the blood vessel at the bottom actually pulsing. You see that? But this is bloodless endoscopy because we have the clear cap which can tamponade it. Once you put the clear cap on to tamponade, you can pass the instruments, and using the clear cap, you can basically hold the blood from coming out, and you can preserve your visualization. This is exceptionally useful in the duodenum and the esophagus where the walls are relatively tight. Here I'm performing standard coaptive cauterization. I first injected epinephrine, and then I'm trying to crush this vessel against the duodenal wall, crush the two walls together, and then seal them using bipolar thermal therapy. Here's my Dr. Pimple Popper moment. Brr, pop, right there. You can pop that vessel, and all that's left is the shell of the vessel that's sealed. That's right there. If you ever wondered what coaptive cauterization was, that's it right there in its clearest form. The clear cap can help you maintain this visual field. It also allows you to create this kind of funny terranium where you just isolate the blood vessel, right? And none of the blood clots can enter into that space, right? Many of you may say, well, I'm not used to using that. Yes, you are, right? Yes, you are. Because you use a band ligator to do varicose bleeding, right? So you're used to having a clear cap on. It's already built into that system. Likewise with the over-the-scope clip, right? The nice thing with those devices is that you can still suction because you don't even need instruments in those channels. For upper endoscopy, position the drainage hole around the 6, 7, 5 o'clock position, because in foregut endoscopy, that tends to be where gravity drains, and therefore you won't have an air fluid level that annoys you during endoscopy. Here's an example of using clear cap plus water immersion technique. It's an excellent combination, especially during push enteroscopy. Okay, it allows you to stabilize the scope. It opens the folds, the clear cap specifically, and then a water immersion softens the walls as well, and it can float that jet of blood in that fashion. So you can exactly see where the focus of bleeding is, and you can pass your instrument. Remember, the instrument channel and the suction channel are the same conduit. So the moment you start passing an instrument, you sacrifice suction to some degree. Let's move on to the second pain point, difficult positions. Okay, here I'm going to discuss clips and hemostatic forceps again. So you cleared the blood clot, right? It's all gone, and lo and behold, the classic cardia doulophoy actively bleeding. You can't reach it with a bipolar probe, but you can inject epinephrine because the needles are relatively flexible. What's next, right? Obviously, what's next is a through-the-scope clip. Through-the-scope clips all have unique features. They're all excellent. They're great tools. They're all very, very high level now, but they have some differences in between. I'm not going to go through all of these, but I do want to highlight to you that the Dira clip, Sure clip, Assurance clip, the Diversitech Replay clip, and the Quick Clip Pro can pass in retroflexion. That means that the Boston clip and the Quick clip struggle. Okay, they are good clips though. The Boston clip can be controlled by the endoscopist, whereas the Quick clip is extremely strong and has the widest angle of opening. Study these clips whenever you go to a conference like this or a hands-on session, and then figure out which one is best for you guys. My favorite clip, if you want to know, is the Steris Assurance Control Clip. It's a next generation clip. It has all the features of all the clips in one, and also comes at the cheapest price. You can control it at the level of the endoscopy as well, to some degree, not so well in colonoscopy. You can see the size of the tails of the clip are very different, and that determines whether or not they can pass in retroflexion or pass through the elevator of a duodenoscope. Here's that case. Epi injection was done, and then a through-the-scope clip can be passed in full retroflexion. Now you may think to me, well, Andy, maybe you're talking about relaxing the retroflexion, then passing the instrument, and then re-retroflexing. I'm not talking about that. In fact, I'm talking about this on the left. Double wheels fully back, locked all the way in full retroflexion. Which clip can pass? It's the three or four that I mentioned to you. So you can see on the left there, that's what I'm referring to. You see that? Yeah. That means that you don't lose any of your retroflexion. All right. Now, that's one difficult area, which is the cardia. What about the posterior duodenal wall or posterior duodenal ulcer? That's that 5 o'clock position that you always want to try to see, but you can never see because you end up falling back into the stomach. You can, I think these videos may not be working that well, but one option is to pass a duodenoscope. The other option is to use water immersion, which can help stabilize the scope. You can see it here, if you know how to pass a duodenoscope, if you perform ERCP, that wall is very, very easily seen by a side viewing scope, and you even have the elevator there to help you perform coaptive cauterization. So water immersion and duodenoscope are two options to help visualize that area. Also, the clear cap is very useful. If that doesn't work, you can switch to a pediatric colonoscope. Now that is mostly because of the instrument location on exit, right? A gastroscope oftentimes comes out on the left for most instruments, and then the colonoscope more on the bottom right. So if you have an ulcer at the bottom right, but your instrument is coming out on the left, you can switch to a pediatric colonoscope. And they make these ultra slim ones now, which essentially are just gastroscope, but they're just longer. And the instrument comes out at the bottom right. So you consider that as well. Now, what about the tough stuff? Refractory bleeding. Now I want to talk about topical powders, over-the-scope clips, and stents. Okay, fully covered stents. Here's a patient who has a duodenal ulcer that rebled despite arterial embolization. And you can see here, I'm hoping that it can be, is it showing? Oh, unfortunately, it's playing on the other one, but not on this one. Yeah, that's unfortunate. Well, I'll describe it to you. See, it's weird that it plays there. Yeah. And the guys in the back, can you hit the play button on there if you can get to that? The little triangle. Yeah, that one. That's weird.
It's playing on the mini one, on the cheat screen.
Yeah. Well, I'll describe it to you. It's this ulcer, and it has a clot on it, and it's actively bleeding, and it has a coil underneath it, and it's actively bleeding, and I push a bipolar probe into it, and the bipolar probe bizarrely goes through the wall. And I think it enters into the blood vessel, I'm not sure. I pull it out and it starts bleeding really bad, and then I use an over-the-scope clip and it works. There you go. These are two different clips that currently are on the market. Avesco makes one and Steris makes the other. The padlock one only comes in one size. That's the one on the right that looks like Game of Thrones. And the other one is the bear claw. That one comes in multiple sizes and it can be removed using a very low-cost generator that they sell at cost. The one on the right, the padlock one, is extremely difficult to remove. However, it's extremely easy to deploy, whereas the Avesco one requires multiple hands and the technician holding. It's even more difficult if you try to use grasping instruments at the same time. Then you have to have the controls here, the scope here, someone's got to turn the wheel, and someone's controlling another device as well. So it's a three-man job. Here's a case of okay, so there's a big vessel that I thought was a little too big for the 10 French bipolar probe, so I used primary over-the-scope clip closure. This is not necessarily guideline recommended yet, and unfortunately in this case it actually rebled, which I thought was impossible, but alas it can. And I stopped it using bipolar probe. This is very safe because it's buttressed on the back end by the clip itself, so it won't energize the clip. All clips cannot be energized by any thermal. The nitinol just won't do it. Here's another case of an angularis ulcer that's very, very fibrotic. I was not comfortable using the bipolar probe because it wouldn't rotate. When I suctioned, I didn't get good capture, and unfortunately, I deployed the clip shallow and early. It shaved the head off of the blood vessel, and the patient began to have uncontrollable arterial bleeding. This is bad, and I'm showing you all my mistakes. But in this case, the only thing that can rescue the day is hemostatic powder. Right? The same reason you don't like hemospray is the same reason I love it, because it gets everywhere. It gets in your eye, but it also gets behind that clip at the interface of the vessel and the clip. So utilize those things, right? If you can't reach an area that's very easy to see, blow the powder in there. It gets everywhere. It will cover that spot. The reason why I screwed this up is actually because I installed it shallow. Those tabs right there that I'm pointing to, you should not be able to see those. If you see those, you have it on too shallow and you're going to deploy. It's going to be very difficult to deploy mechanically, and you'll have a shallow deployment. If you have torrential bleeding, have the technician grab another scope and preload your rescue device on it to save install time. That way it's ready on a dry scope. That way you can just pull the scope out, hand me the other scope, and they're doing the ta-ta-ta-ta behind you. You're passing it, you've only wasted 10 seconds. I think everyone in this room can pass a gastroscope blind at this point and get at least to the mid-body in 2 seconds, 3 seconds. Here's the worst bleeding of my career. This is a GDA, I think it was a pseudoaneurysm, honestly. And it's not even pumping, it's just like flushing out. And in this case, hemospray is the only really way that you're gonna have any chance at stopping this. You're doing this while the nurse is calling interventional radiology. Okay. The reason why I think hemospray rather than the other powders is because hemospray gives you an unlimited amount of ammunition. You get 20 grams of powder relative to 3 versus 5. It also has massive amounts of carbon dioxide velocity, so you don't need to worry too much about barotrauma, where the other devices push out room air. I think hemostatic powders are for the 5 can'ts. These are the indications. Can't stop, can't reach, can't finish, can't touch, and cancer, pun intended. Okay, can't stop is rescue, can't reach are those tough to reach areas. Can't finish is diffuse bleeding, you'll be there by tomorrow. And can't touch means you can reach it, but you don't want to touch it, right? Like the papilla or a diverticulum or a thin-walled ulcer, right? And cancer is cancer. So hemospray has these limitations. Blood is pooling actively. You're not allowed to suction according to the instructions of the manufacturer. You got to dry the scope, you got to flush it with a bunch of air, and then once you get the catheter tip down there dry, which is a feat in itself, now you can't get it wet, but remember the patient's uncontrollably bleeding, right? That's a tall order, okay? So there is a way that I invented that you can use this bone wax stuff. You can find it in the orthopedic room. They used to use it in EUS to keep fiducials inside the EUS needle. You put a little bead of it onto the tip of the catheter. Connect that to a 3-way stopcock, connect that to the gun, and on the 3rd way of the stopcock, you connect an air flush, right? And the bone wax basically prevents it from getting wet. It's just like a hydrophobic tip, right? So that's the setup. You can see it didn't take very long, right? And it only cost like $5. You can find the bone wax in the orthopedic OR. So here's the catheter tip. Put it in the water. It's getting wet. That's usually a no-no. Blow the bone wax off like a booger. Turn the stopcock and fire, right? If you do it this way, you don't have to clean the scope or do anything. There's no other preparation, right? In addition, if you use the 7 French probe with the therapeutic gastroscope, you can still suction in the annular gap between the catheter itself and the inside of the channel. And so I don't use the 10 French anymore, I just use 7 French. Here's it in vivo. Bleeding gastric cancer, catheter tip is getting wet, suctioning, usually that's a no-no. Blow the booger off, boom. Turn the stopcock and fire. That's it. It's an off-label modification, I have to say that, but it works extremely well. And if I die tonight, there will be a footnote in history that I helped somebody. I get messages all the time that it works. If you don't like that and you think the bone wax is weird or whatever, then you can borrow the CO2 from the back of your scope and do the exact same thing. Add the carbon dioxide flow from the back of your scope. Remember earlier we borrowed the suction? Now we borrow the CO2. Hook that into the 3rd way of the stopcock in lieu of the air flush. And now you're having continuous airflow of CO2, through the catheter tip, and it'll never get wet. Now you just got to train your your technician to just switch between ammunitions, right? So there's the regulator, there's their CO2. It connects all the way to your scope via this thing called an endogator. Disconnect it right there, right? Okay, and then on the second panel, you can see a continuous flow of CO2, right? You can pass that through the scope. You don't need to flush the scope, it's flushing the scope for you. By the way, while you pass it, if you suction blood, it still won't clog. I don't understand the physics, but it works out, okay? And then finally, when you have it ready to go, you can just tell the technician to turn the stopcock whichever way you want it. If you want powder, then oppose the CO2 with the stopcock. If you want CO2, then oppose the gun. So you can see there's a continuous flow of carbon dioxide. It never clogs, it cannot clog. Okay, and then you can basically fire. I think this is like a bleeding gist or something that I couldn't control with a clip that had to go to the OR. Here I write no need to turn the stopcock. That's if you have a 4-way stopcock, which is basically a splitter. You do need to use room air to clean the lens, okay, because it gets a little snowy stormed, but it works very well. Okay, there are 3 different powders currently available on the market. There's also a gel called Puristat that's mostly for prophylaxis, in my opinion, for EMRs. The important thing to remember here is that hemospray gives you 20 grams, it's delivered by CO2. The other devices are significantly cheaper. They're $750 to maybe $1,200, but they give you much less powder. They do have a kind of a gel morphology after a little while, so they're very useful. The EndoClot one has a compressor, so if you're doing a travel case, don't forget to bring that thing. I like them all, they're fine, but for the real killers, you need a lot of ammunition. I wrote a paper in January at GIE, a review. It's like a Yelp review for all the topical agents, including Puristat. And I invite you to read it if you're trying to decide between these agents. In the Annals of Internal Medicine in the last 2 years, 2 randomized trials were published that both had to do with endoscopic devices. That's right. The Annals of Internal Medicine published a device study, a randomized trial. And you never read it because you don't subscribe to the Annals of Internal Medicine. I know, right? These 2 studies are landmark trials. One of them compared hemospray to standard of care in non-variceal upper GI bleeding lesions as primary therapy. The other one compared over-the-scope clip versus standard of care for the same type of lesions. They were both published from the Chinese University of Hong Kong, which for the last, 30 years has been publishing all level 1 data for peptic ulcer disease in Asia. And they always get published either in New England Journal or Annals or something like that, right? And they showed basically that hemospray as primary therapy is no different at 30-day rebleeding than standard of care. So just because that powder is gone in 1 day, for some reason, and yes, I'm surprised too, it has the same rebleeding rate as if you used bipolar and epi. I don't get it, but that's the data and I can't argue against it, right? In terms of immediate hemostasis for big active GI, like arterial bleeding, like usually Forest 1A, it was superior. In terms of over-the-scope clips, it showed some signal for being basically overall superior to the standard of care. And that makes sense because it's just a bigger clip, in my opinion, right? Last case here, refractory esophageal variceal bleeding. This person had banding before. That was an ulcer there, but actually the active bleeding is happening right there, right? I was tamponading and now I revealed it. It's actively bleeding. It's right in the center. Okay, suction. Come on, Andy, suction. 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 Not working. It's not getting a red out, right? I don't know what to do. I'm desperate now. I'm sitting on I'm holding the suction, right? It must be too fibrotic. I desperately deploy the band. There's a ligation failure. I suction, now the band clogs the scope, and the patient's now arterial bleeding, I have to get a new scope now, right? That could be because it was too fibrotic. But actually, the reason why it didn't work was because the nurse was standing on the suction, okay? And it was in the ICU, and I couldn't hear. The ICU is a very noisy place. The dang ventilator is like, and it's making all these sounds, you can't hear anything, right? So I didn't recognize that. Right? And then I ended up having to deploy a stent, but it turned out the suction was just not working. From that point on till now, I always suction my finger before I start the case. You should be able to suction your entire glove you should be able to blue out your glove. Do that every single time. Now, if it truly is fibrotic and you can't suction and you tried sclerosant or ethanolamine or whatever, then I encourage you to learn how to deploy this new technology. This is a fully covered self-expanding metal stent. But the reason why it's new and shiny and special is because it can be deployed through the scope. Through the scope. In the last 6 years, we have finally developed technology that can pass through the scope, fully covered self-expanding metal stents through therapeutic channel. We could not crack that technology for the longest time, and it required an interventionalist do side-by-side endoscopy with the guide wire in order to deploy it. Now you can just push it out of the scope. So I think the general GI should be able to do this. One is, there's 2 companies that sell it, and they work very, very well. A randomized trial showed that they're superior to the Blakemore tube. In our unit, we have a joke that the Blakemore saved as many as it killed, right? So I encourage you to try to learn how to do that. There's one last case. This is Lath's favorite. Refractory GAVE. Oh, the video is not working again. But it's GAVE, and I'm banding it instead of using APC. And in my opinion, the guidelines will change. Band ligation should be the first line treatment, or at least combo therapy with APC. And band ligation for GAVE, especially nodular GAVE, is superior in every way, which is my favorite 3 words, superior in every way. My only recommendation is don't band too close to the pylorus. You get a little partial gastric outlet obstruction, and the patient will get nauseated. I have a bonus case, but I'll save it for, if you think you have time? Is it okay? I'm the last case? All right. You have APC in your electrosurgical generator that does not require argon gas. It's called spray coagulation, okay? It's a form of non-contact thermal coagulation that's just like APC, except it only requires a $12 snare. It's used by surgeons and ESD doctors in Japan, but it hasn't caught on in the United States. It has the exact same principles as APC, but it doesn't need argon gas to create the plasma arc. Basically, a high voltage electrode tip, which in this case is a snare relative to the mucosa, creates the plasma arc through air and not argon. The burst of high voltage electricity quickly dampens after it fulgurates, which is basically after it gets dark and crispy, and then it auto limits its depth of injury. This is even particularly more safe if you have next generation ESG that can detect impedance, right? So you're like, what is this guy talking about? Okay, that's a chicken ex vivo. Maybe that one doesn't work. Okay, look at the right. That's Gave, and see, I'm burning it. But you see that plasma, the little argon, it's not argon. That plasma arc is created just through room air. That's just a snare, right? That's just a snare. You have this buried inside your electrosurgical generator. It's located right below soft coagulation. So next time you're there, you can check it out. I use this to cauterize Gave. A histological study showed that it's very safe. Spray coag at 60 watts is about APC at a higher dose setting. I use it in the stomach and I use it in the rectum, okay? Its cost is very cheap. APC probe's about $200. Don't even ask me what it costs to replace the argon bottle, okay? It's very convenient because you don't have to bring the argon system. If you're doing EMR or ESD and you get bleeding, you already have the snare, right? And for belly breathers, I love it because you don't have to hover like you have to do with APC. You can actually make contact with it. Now, why? Why can you make contact with it? Because you can pull the snare tip in just inside the catheter. So that if you contact it with the catheter and you burn them, you're not actually making direct thermal energy. It's almost like a device has its own clear cap. Huh? Like you have a clear cap and your little baby alien has a clear cap, right? And so you can make direct contact, and it also won't make that frightful argon bleb that sometimes we see when we directly contact with argon. So these are the take-home points. I know I've run over time, but hopefully you'll forgive me. Reposition the patient if torrential bleeding is pooling atop of the source itself. A clear cap can be very useful to tamponade a blood vessel to allow time for instrument passage. Not all through the scope clips or over the scope clips are created equal. Bone wax plus a stopcock or borrowing your own CO2 from the scope can optimize hemospray delivery. Hemostatic powder, specifically hemospray, is no worse than standard therapy, and over the scope clip may be better. Refractory esophageal bleeding can be managed by through the scope fully covered self-expanding metal stents, which in my opinion can be placed by the general gastroenterologist at the bedside without fluoroscopy because now they are through the scope. Yep. Consider banding Gave. Oh, and diverticular bleeds, but that's for another talk. Spray coagulation is a poor man's APC. I hope you learned something. I really hope so. Thank you so much. Oh, sure.
Absolutely, go ahead.
Okay, so we always did a second look after hemospray the next day, right? Or the second day. But now you showed us data that it's as good as primary hemostasis. Have you changed your practice?
No, I do relook. I do relook on a certain patient. I look on the certain patient where I feel like on the second chance, I'm gonna do something durable. Like I'm gonna put it over the scope clip, right? And I also relook if they need to go back on their blood thinners. Okay, because that variable is different, right? Because usually the ER stops their Eliquis or whatever before I scope them. So I feel like I'm cheating with the hemospray. I'm doing hemospray without Eliquis, but I'm about to send the patient home and restart the Eliquis or start it in the hospital? No, I prefer to relook and do something durable. Now, if there's no point in relooking if you don't have a plan, just to relook. So you want to have a therapeutic plan for the relook, If you don't have a plan, I think diagnostic is no benefit. Yeah.
Okay, thank you.
Dr. Tao,
yes.
I think your talk was superior in every way.
Oh, thank you. I appreciate
it. The question that I have is sometimes I've used BioVac. I don't know if we're allowed to use that terminology to sort of increase the residual. I've had a hard time, especially with those clots in that fundal area. I've tried putting the head up. I've tried moving positions. But sometimes there's these large adherent clots and I don't have access to that device that you mentioned.
Right.
Have you had good experience with BioVac?
Yes, the BioVac is exactly equivalent to taking the suction port off the back of your scope and connecting it directly into the biopsy channel. The BioVac is a device that's made by Steris, and it essentially works exactly the same way. The benefit to that is that it has a little button that you can control. Yeah, if you take the suction off the back of your scope, you plug it in there, and you have the nurse bend the tube, you've just made yourself a BioVac. And when you're like, okay, suction, she unbends the tube, Okay, stop. And she just bends it. Okay, you've made a BioVac. So essentially that's all it is. Is it useful? Yes, but it's only useful if you combine it with a large mouth scope. If you have that 6 millimeter GIF XTQ160, that big thing, and you combine that with the BioVac or this method, a little bit of choppy with some cold snare, and you're going to clear it up. Yeah.
Great talk. I have two questions.
Sure.
There've been a few small studies that have talked about using the hemospray for varicose bleeds.
Yes, there are.
What's your opinion on, if you're not getting anywhere, you're sort of you're going to get him to IR, but you're going to, instead of putting in a Blakemore, you're willing to just throw some hemospray down there and try to hold it until
I've certainly made a hemospray sandwich before, where I spray hemospray and I put a stent over it. I have done that. The trial that was done, I think it was done in Egypt. It was a randomized trial, but it was a little different setup. They basically used hemospray as a temporizing device so that they can get the patient to a higher level facility where there's more endoscopic expertise. And in that case, it did show value. But it wasn't as clean a study as the ones that are done in China, for example. Now, I have another comment about the hemospray. I have a feeling it doesn't really work in varicose bleeding for two reasons. Because hemospray relies on endogenous clotting systems. It requires on platelets to be intact, and it requires the clotting cascade to be intact. And as you know, cirrhotics ain't got either of those, right? They have 40 platelets during endoscopy. Anesthesia is always asking if you want to give platelets, and you're annoyed by that. And then they're also asking, oh, should I give fresh frozen plasma, which you absolutely should not do that, right? Because these cirrhotics are coagulopathic and thrombocytopenic, hemospray relies on both of those systems in order to form a clot. That's why I don't think it got FDA approval. And that's why I think a lot of these hemostatic powders, which rely on basically dehydrating water and allowing immediate clotting factor and platelet aggregation, don't work in very ill cirrhotics. In desperation, go for it. Yeah.
One other quick question, just your opinion. So the latest ACG guidelines, when it comes to an adherent clot, they don't have an opinion. What's your approach to? Do you case by case, or you pull clots off all of ulcers?
I would say that I do pull clots off all the time, but I do this for a living. Now, for the weekend warriors out there, like my partners who are on call and when they see a clot, you know what they say to me? That's God's work right there. Don't touch that, right? And the guidelines say that that's okay. But you have to accept one thing. If you are a weekend warrior and you leave that clot on there, you must accept 25 to 30% rebleed rate, right? And if the person's going to restart on Eliquis or something like that, that's a really high risk, right? Because people die on the second rebleed, not the first bleed, not the index bleed, right? So for that reason, I try to perform durable hemostasis, but I wouldn't fault you. Now, on that paper that I wrote in January about topical powders, if anyone here is itching for some research, you should try to develop a protocol in which you apply a topical, not the powder, but maybe the gel like Puristat or something on there, onto an adherent clot and see if you can stabilize it. Because it would be very, very attractive at 3 a.m. to say, ooh, look at God's work. And look, now I'm going to put man's work on top of it. And you put some gel on there, and you can sleep through the night, and it shows that they have maybe half the percentage of rebleeding, right? These studies are easy to perform because you no longer need to have it randomized, because there's such a massive wealth of historical data that you can, I don't know, there's statistical methods, you can do matching and all that type of stuff. Yeah.
Thanks. Hi, my name is Ratweg. I'm the first-year fellow at Sparrow. Great talk. I have two questions.
Sure.
One, for the higher hemoglobin target in patients with ischemic heart disease, doesn't matter when the ischemic heart disease was. Like, what if the cabbage was in 1990 and they've been stable just on aspirin since then?
Yeah, I think it's reasonable to maybe split the difference for that guy. Maybe not go to 10, maybe go to 9. That's where the art of medicine probably lies. But I would still be very careful. It's crazy, maybe just because I got burned, but I always make sure the patients aren't having chest pain. Yeah. But I generally aim for 9 to 10 for those people, even if they had remote coronary artery disease. Yeah.
Okay. Just another one question. When your cauterizing with the gold probe. When do you lift the probe off the tissue after cauterizing it? Like underwater, lift your foot off the pedal? When do you do that?
Yes, yes. So the guidelines actually state that 15 to 20, maybe a little higher, is the wattage. Okay, but the key thing is that they insist. The guidelines literally say this, to hold for about 10 seconds. That's a long time, 10 seconds, right? And if you were to count 10 seconds when doing it, you'll count like this: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, right? But that's why I'll show you a video one day, or maybe I'll post it to my Twitter. When I count to 10, I make my assistant count to 10. I say, count to 10, real seconds. 1 Mississippi, 2 Mississippi, 3 Mississippi, and we're burning at 15 watts. I'm very uncomfortable. Even to this day, I feel, gosh, it's a long time, right? But you have to seal that vessel. You have to crush it, and you have to seal the two walls together, and you have to melt them together too, so that when you come off, they don't open up, right? You're really doing, you're really gluing them together using heat, right? And so I burn for 10 seconds, okay? And then I put the water jet to connect to my bipolar probe. It has a hole.
Yeah.
And then I irrigate a little bit with the water jet, and I still hold it there for a long time, right? And then I tell everyone in the room, like, I look at anesthesia, everything's fine. Okay, do you need more blood or anything? You know why? Because right now, everything in the world is okay, right? I have it cauterized, I have it tamponaded, there's no bleeding, okay? Sometimes I've even sat in that position for 20 minutes, just holding it there, because we needed more blood, because we lost a bunch in the last 10 minutes, right? And I said, okay, well, they're like, doctor, are you okay? Are you comfortable? I'm like, I'm okay, don't worry about me, I'm fine, right? Relax my shoulders, I'm just holding position, everything's fine. And then we wait for the pressure bag to go in, another 250 cc blood is in, okay. I take it off, boom, it explodes, right? But at least during that period of time, I had an opportunity to get some blood back in there. So don't be too eager to, I wonder what happened. Hold it there for a little bit, right? Also, when you pull the bipolar probe back and you let go of the scope, have the technician hold the scope for you.
Okay.
Okay? Because you want to maintain that position. Right? This is a very high level question you're asking, but you want to have the technician hold your position. That way, you can do what I call like a little peek, right? You can take the bipolar probe off, really you're not pulling it to the side, you're pulling it back into the scope, right? And then if it's bleeding, you push it right back in, right? Right? But if you don't have them holding the scope, you've lost your vector, you're somewhere else, right? You need to be right on top of that thing, right? Pull it back, and then if it's still bleeding, put it right back in. Take a deep breath, and then continue to cauterize. At that point, I go 20 watts, and I go another 10 seconds. Can you believe that? Yeah. One time I was doing this, and the surgeon was watching me, and he was just shaking his head. He said, God, you guys are some real barbarians in here. He says, what happens when that perforates? Burning for 20 seconds? And I was like, well, that's what you're here for. Yeah, anyways, it's difficult, but I would use a little water, and I would keep my position.
Okay, thank you.
Andy, great, thank you, and thanks for coming, really. So you mentioned something about IV PPI, it hasn't kicked in. That we were recently approached by a pharmacy saying, well, studies show that oral PPI BID is the same as like 80 IV and IV drip or something.
That's simply just not true.
Yeah. There's studies, right? That
Correct.
Show,
Yes.
So what's and of course we want to fight this because one, doesn't make sense, although the studies say, but that's somebody throwing up blood. Well, you can't give them an oral PPI, right?
Right, exactly.
But, so you still, of course, you do the 80 IV and the drip until you control the bleed.
Correct, if they're in bad shape. If they're in hemorrhagic shock, I use IV drip. If they're not, then I use IV BID, and I never just use oral.
And let's say they're, the stable one that you're going to scope tomorrow. They have melena, hemoglobin is low, they're okay, you see them, their score is 1.
Yes.
You're like, okay, put them on for tomorrow. Do you still do an 80 and BID IV, or do you say, okay, fine, this one looks like they can take oral?
No, I scope first, and then I switch to oral a second.
So you keep them on no PPI till the next day?
Oh, no, I'm sorry. At the point of contact, I give them IV BID.
Okay.
Yes. After I scope them, then I'll rapidly switch to oral if it's appropriate. Yeah, that way I can kind of save the money that direction. If they're in the ICU, it's drip.
Yeah.
It's very easy. ICU, drip. Floor, IV BID. And then after the endoscopy, then I'll adjust.
Perfect. Thank you.
So my question is about the refractory variceal bleeds. You mentioned the use of stents, and we're finally going to get the Taewoong fully covered through the scope stents.
Yes, it has a 22 millimeter inner diameter, so it's very good at tamponade, yes.
My experience is they're very slippery stents,
Yes.
and they migrate quite frequently. What is your method of adhering them? Or do you typically just stent fix them given the time frame, or
Yeah.
because it's usually a bridge to something, right? It's usually a bridge.
It's a bridge.
To tips.
It's a bridge. So I usually don't I don't deploy the stent fix OTSC clip because while it's very good, then I have to go remove it afterwards. Yeah. Okay. Instead, I do affix the stents. I obviously don't let them eat. If they eat, I believe that those stents migrate 100% of the time if you let them eat. It's food to them. The esophagus is like, delicious tube, right? And onto the stomach it goes. But the way that I fix them is I put 2 mantis clips on them.
Okay.
And when I grab the mantis clip, right? You guys know that. I grab buckets of tissue. Like the mantis clip, you can grab it and then you can shift and then you can grab it. Yeah, I do that. Even though I can just grab it, I don't. I grab a huge chunk of tissue, right? And then I open it up and then I just shift it over, and all I need to grab is one piece of metal. The metal's not going to break, it's the tissue that's going to break. So you need to grab as much mucosa as you possibly can, and then one tine of the metal lattice, and then you got it. And then do that on the other side. You're just trying to buy 2 or 3 days, yeah, until IR can come in, yeah.
Hi. Where do you see the role of the matrices, like the 3D matrix for hemostasis?
Yes, the Puristat, yes.
Yeah.
It's the only FDA-approved topical agent for prophylaxis, so a lot of people use it after EMR, ESD, or any type of resection. It's also, people use it a lot for when they do ampulectomy, right? There's no really good options there. They put the stents in and they try to use it there. I think it's good. I think it does serve a role. Now, it doesn't have FDA approval to stop arterial bleeding. Okay, so I think it's great for oozing type bleeding. And also, I tend to use it for post-sphincterotomy bleeding. Okay, the value of it is that it's clear, that you can see around it. So if you apply it and you have more things to do later in the field, it doesn't block your vision.
Like if you have a really big ulcer, 4 or 5 centimeter ulcer, that regardless what you do in terms of hemostasis, there is a high risk of rebleeding. Would you use that in addition to your hemostasis?
I wish someone would do a study about that, as I said earlier. But to be honest with you, I do apply. I epi and bipolar, for example, and this big 4 centimeter ulcer, so big, all these little red spots. Who knows if they're blood vessels? I don't have the Doppler thing. Yeah, I put Puristat over it. I do. I don't know. Hopefully one day the research will show that is either real or it's not real. Yeah. Maybe it'll be as good as nortriptyline for functional dyspepsia. It's just pure snake oil. Who knows? Okay.
I think the timing of endoscopy is an important point. We often kind of get stuck in the middle of the night, the scope, the no scope question. Your point's well taken. There's that sweet spot in the curve where you scope too early and they actually do worse. And I'm curious, we get the nervous ICU resident at 1 o'clock in the morning. You think they're probably under resuscitating. You're getting hammer paged by the team. You're not really sure where they are on the resuscitation cycle. I think most studies would show that if we go in too early, they can do worse. And yes, we do much more endoscopic therapy, but the outcome might not actually be any different.
That's right.
Had we not done the scope. And so I'm curious, it's often a case-by-case basis. You've got the 1 a.m. phone call. The team is panicking. You think they're probably going to file a complaint about you if you don't come in. But you think they're probably under resuscitated.
Yeah.
How do you handle those?
Yeah. I come in.
Yeah.
I see the patient. I shake their hand like a creepy Bill Clinton. I do everything. But I don't necessarily scope them right then. And that's the difference. And that's how you quell a nervous resident. You stand next to them. You shake their hand like a creepy Bill Clinton. It's going to be all right. Massage that elbow a little bit. The most practical tip I can give you is that if the patient on the next recheck CBC has not responded despite however long it takes to get IV fluids, get blood, give the appropriate amount that you thought on their first swing at it was right, and then CBC you recheck and it's not appropriate, it's time to perform endoscopy after I hang the same amount of blood again. So So let me give you an example. All right, someone is having hematemesis, they get admitted to the ICU, they're giving IV fluids, they've ordered blood, the hemoglobin is 6, but this person is a cirrhotic, right? They had fresh blood in the ER, but it seems like not right now, but they are nauseated, so you're wondering. And so I tell them, all right, I want you to hang, it's hemoglobin 6, I want you to hang 2 units of blood, right? Antibiotics, octreotide, everything. After that 2 units of blood, I want you to check the CBC. Right? If he checks the CBC and the hemoglobin is 6, it's time to go. You're going to be hanging blood till 9 a.m. It's going to be 6 when you go then too, right? They can bleed as fast as you can give it. They can, right? And so if at the first CBC, all my best efforts, and I'm there too, monitoring the resuscitation, if my best efforts have failed, it's time to perform endoscopy within 12 hours, basically. Yeah, it's urgent. Yeah.
Even in non-cirrhotic patients, similar.
Similar, yes, because those people probably are bleeding from GDA. That's the only other, or Dulafoy. Dulafoy can bleed that hard too. Yeah.
Thank you.
Do not be misled to believe that a patient cannot bleed faster than you can resuscitate them. I promise you they can. Yeah.
This is the last question I'm going to ask. This is Dr. Tao. This is fantastic once again. But I got just from a practical perspective, what do you bring with you when you're coming into a bleed? Like what are the things are you asking, hey, nurse, grab this, grab this, grab this? Yeah. What do you got in your little Lululemon?
It's not little. It's not little. We actually bring an entire cafeteria cart. You know the cafeteria cart that they bring over here to get your coffees and stuff like that? We bring an entire one that's always stocked. We always say if we bring 10 clips, why not 20? Right? If you got 1 hemospray, why not 3? Right, so that thing is packed, and I know it's annoying because it's like another thing that you have to roll up to the ICU, but we have everything in there. We have epi, we have our sclerosants, we grab Pyristat, we have at least 2 hemosprays, we have 20 clips on there, we have everything in excess. I have the stent, I have a Blakemore too. It's probably expired, but yeah, we have everything in excess. Yeah. Oh, my Lululemon bag, I carry a fanny pack around. Yeah, that thing is weird. I'm a little embarrassed to say, but I have a lot of things. You'd have to look. One of the things that I have is a clear cap in there, unused, right? And then another one is I have another type of clear cap called the Avesco FBR cap. It's a mega cap. It's very, very big. I use that for food boluses. That's another lecture, right? I carry nitroglycerin. The people for angina, but I carry it because I compound my own anal fissure ointment. You're embarrassing me now. Yeah, yeah, all the time. Yeah, it's a lot of funny things. I have a scope brush in there, but I have bone wax. I do have bone wax. Yes, the peg tube kit. I always have them wash the hemostats and the scissors. If I ever have to loosen the peg tube, I don't like to just pull it up. I put the hemostat underneath the flange, I clamp it, and then I wiggle it up. That way the patient doesn't scream at me or punch me in the face. And so things like this, yeah.